now this patient, other thing I told is, suppose somebody has got tinnitus. Before surgery, so many patients we are sure they have tinnitus. But after surgery, patient has become deaf on that ear. Understand? Amrita, what will happen to tinnitus then?
Tinnitus will disappear.
Yeah, agreed. So once the hearing goes, tinnitus will disappear. It will may not. Understand? It is, even if you lose hearing, tinnitus may persist because it is deafferentation. Like, phantom pain, tinnitus is like that because of deafferentation and cortical, our cortex cannot, it malfunctions, it cannot adapt. Maladaptation, it produces a phantom pain-like thing, a deafferentation, so it can still persist. Understand? So that means, after surgery, your patient has lost the hearing. Some hearing was there, but they have tinnitus. You will tell, oh, now your hearing is coming back. It is bullshit. It will not come back. You have damaged the nerve. Understand? So otherwise you can tell, oh, now he said, okay, I am hearing some sound tinnitus. That is, deafferentation tinnitus. That means it's gone. So if they have a fellow who has become deaf and they continue to have tinnitus, if they don't have tinnitus means sometimes their hearing may come. If you have preserved that, other is deafferentation. Understand? Okay. Now that is a short cousin of that. Understand? Always you should tell about tinnitus. No history of any tinnitus. Other thing. Can you go to the next slide? The next slide. Other cousin is, they give this, this vertigo sometimes, 5 to 5% of 6 and less than 5 to 10% of patients can have history of spinning sensation, which would have been there in the past. That history you have not told. So any peripheral vestibular involvement. If it is acute peripheral vestibular, definitely they will have some spinning sensation. Either they tell that environment is spinning, or they will tell that they themselves are spinning. So that history also was not forthcoming. But after some time, if it is a peripheral vestibular involvement, there is central adaptation that will go. They tell to begin with we have this problem, especially if there is a tumor which has been there indolent for many years, and suddenly something has happened, like some bleeding inside. Suddenly they gave that vestibular dysfunction. Understand? So otherwise, slow vestibular dysfunction means always there is a central compensation. Understand? They may not get, but very few percentage of patients can still have in the history, past history of this spinning sensation. Understand? How much time I have for this long case? Plenty of time, no problem. Okay, plenty of time. Okay, so 9 to 11 is our first case, 11 to 1 is the second case.
Then one break is the second.
So break, and don't worry, don't bother. Okay. Okay. So understand. So that history you should tell, which was not there. Understand? Okay. So 3 cardinal history is hearing loss. The other history is tinnitus. Other history is any history of any vertigo. The vertigo is different from many people. They put dizziness, giddiness, everything together. Understand? But there are many people, they put this unsteadiness or just giddiness or this pre-syncope fear, functional, everything together as vertigo. Vertigo is true. Vertigo is true spinning, which will not be there for other unsteadiness. Okay. Okay. Then, so always if it is there, you should know whether it is episodic, spontaneous, or it is lasting for few days. Understand? Whenever vertigo patient complains, sometimes it will be a spontaneous. Understand? Spontaneously it comes, or it could be a chronic vertigo. Understand? Or sustained. Sustained vertigo you get for some infection, viral labyrinthitis, those things you can get. Even for a non-compensated central lesion also you can get, like vestibular carcinoma, or they can also you can get. Certainly the endolymphatic eye drops, it burns. So the endolymphatic eye drops, they are very rich in potassium. When it mixes with the perilim, sudden depolarization occurs. So they go for severe spinning. Understand? That is called episodic. Understand? The other is spontaneous. What you get is your benign position, and all you turn, suddenly you get. So you have to know whether it is spontaneous, episodic, or sustained. Sustained you get in central disorders. Usually you can get even a sustained vertigo for, normally you get for viral labyrinthitis, vestibular neuronitis. Viral labyrinthitis, you will have hearing loss also, infection, autoimmune problem, those things, and also for some central disorders it can still persist. Understand? Vertigo. So that history also you should check. Understand? Another thing, it is totally different from unsteadiness. Disequilibrium. Disequilibrium is because of either a central problem, brainstem problem, cerebellum problem. They can have disequilibrium. So many people, they mix everything together. They said everything, they are dizzy, giddy, but really they are not having vertigo. Understand? Vertigo you get for very few. Our peripheral thing it can produce. Peripheral means from till it reaches the vestibular nucleus, it is peripheral. Understand? From the end organ, your cupola or ambula or whatever it is, till it reaches the vestibular nuclei, it is periphery. Once it hits the brain, it is central. Understand? Central problems are migraine. Migraine can produce vertigo. That is we told it's all episodic. It can come like that. It is not constant. It will there for some time and go. Understand? Okay. So now coming to the next history. See here. Here telling the walking problem. Ultimately, you have to tell whether walking problem is from peripheral neuritis, or from vestibular dysfunction, or from cerebellum, or from ophthalmic problem. Or you have to tell whether it is from pyramidal weakness, or we have to tell whether it is weakness or just the peripheral neuritis problem, or eye problem, or a vestibular problem. So you have to tell all the sensory inputs and tell from where the sensoriness is coming. Because everything can produce sensoriness. Understand? You analyze and tell from where it is coming. Whatever you have told, you have to tell now. You have suddenly put it in the cerebellum. I am not convinced. So you have to tell where is the cerebellum.
On history, there is a broad-based gait and swaying on either side. With there is no tightness of legs or no worsening of gait in that. As per there is no.
Brother is a doctor. Right? That fellow is tested. He is a neurologist, I think, man. Yes, brother. That's we have written like that only. Brother is telling wide open. It looks as if the brother is a neurologist. Why he brought the case to you is the big problem. Okay, so you are telling why you thought it is cerebellum, not vestibular.
Sir, no sensory attacks in history, sir. There is no worsening of gait in that. Other history are no negative history are not included. There was no portable like sensory running.
That you should tell. There is no history of diabetes. Those things that you should tell that, because it could be ataxia could be from anything. Understand? Let's say it could be from cerebellum, posterior column, or peripheral sensory neuropathy. Everything can produce. Something you have told. No worsening in the dark will rule out. So cerebellum, in spite of opening the eyes or closing the eyes, whatever it is, they will fall. And you have written that a patient walks with broad-based gait. No? Okay, that's what you have written. No? Yeah. Walking imbalance on standing. Just on standing also severe imbalance.
From last 15 to 20 days versus
Okay. Okay. So where do also I have told that eyes wide open and feels and what and feet and feet is not there, man.
Feet.
Yeah, feet is plural. Okay, feet turn outwards and gradually it worsen, and now she has severe imbalance on standing as well and need one person's support. Okay, so based on this you thought it is a cerebellar involvement. No, we'll come to analyze cerebellum later. After clinical examination we will dissect cerebellum. Understand? Okay. Your next slide, no history of weakness. No, that you have told, you know.
Yeah, in negative history. At the end I have told.
At this point of time you should tell that also, no?
Yeah.
Because of unsteadiness and all, we do not know whether it is from any weakness or something. That you should have told. Understand? Okay, next.
History of reduced taste sensation since last 1 year.
Yeah.
Initially she appreciated while eating sweets.
Yeah, I got it. The taste sensation is there. Okay. Okay. That is for the last 1 year patient has reduced. Okay. Next one.
History of
Deviation. Deviation of the angle of the mouth. Drooping you should not tell. Next. Okay. Okay. So what do you think it is? Because decreased salivation, no?
So there doesn't
no
give
history of decreased
There
salivation.
doesn't give any specific history.
And so, this you think it is because of seventh nerve. That's what you are thinking. Right? This is for 1 year. Okay, your next history, can I just check?
That's just old history.
Go back. So you should, that she prefers to chew from the left side. Why? Because?
Right side.
Right side. Chewing, because, now it looks as if, she has a problem in chewing from the right side also. So the better thing is, you should tell that food particles, they stay inside one side, and that is why, if she chews from the what is that side? Left side.
Right side she is.
Why she is chewing on the right side? Explanation. Why they do is, when they chew from the affected side, because the fifth nerve motor from your history is still normal. So they can chew, but the thing is the food particles will stay inside. That you have written?
Yes, sir.
Yeah, correct.
Yeah. Food particles
So we have written that. So they are taking it to the other side and chewing, so that it won't get stuck to the, okay. The other important thing what you have told in 7th is, it is not decreased history, you have tear secretion, whether it is reduced or not, that is not coming.
I've asked her, they did say.
We have to try to that because it is a part of 7th nerve only, secretomotor fibers. Understand? 7th nerve parasympathetic secretomotor fibers, they come through this GSP and without relaying in geniculate ganglion. They do not relay, but they go to parasympathetic fibers, they go to through this gatus petrosal nerve, median nerve, like that, then they go to
Which one?
this what gland is lacrimal gland. So that history you should get that, it should get involved if the lesion is not that 100% it should get involved, but if it is getting involved, you can put the lesion more proximal. Understand? Suppose if it is spared, you still don't know where it is. If it is inside, because especially there is another lesion which can come with facial palsy, everything is facial nerve schwannomas. Understand? Usually it arises from the there is a geniculate fossa in the middle fossa. So the labyrinthine segment, then it comes to the geniculate fossa, then DSPN comes. So if it is arising there, they will have facial palsy, but they will have obvious involvement of this secretion. So that is what, if it is there, if it is only there, if these things are there but other things are normal, hearing is all normal, you can tell that the lesion is somewhere there. If it is affected, you can get it, everything together, you can get it proximally. Understand? Hearing with tear secretion, everything is getting affected. It is either in the canal or proximal to that. So that history was not coming. You should write there. I specifically. There is some test also, Schlimmer's test people do. So that history, sometimes they will tell that when I get emotion, I am not getting any tears from my, that they will, you can ask the leading question you should ask. Okay, next thing. Next slide. So many things, this thing we have. So ICP, this thing, why did you think it is ICP headache?
So, it's a severe type of colorectal headache and rebound vomiting. Transient relief is there and it's associated at the peak of headache is vomiting and plus she underwent shunt surgery.
That's forget about shunt surgery. What will tell that it is a raised intracranial pressure headache?
Vomiting at the peak of the headache, sir.
If migraine people can also vomit. I have seen people ask Komal, he will tell. I used to get migraine and my firing also I used to make it more. So just vomiting doesn't do anybody with headache, if they are very well, they will go and vomit.
Rhinal variation.
Early morning you can tell, but how many cases you have seen early morning vomiting? It's all test tube only. After that, they should do like that and throw out their carbon dioxide, and so that ICP will become less. That is all test tube, you can tell. You won't see anybody in the morning vomiting without nausea, and after that, they have to reduce their carbon dioxide. After that, wash out carbon dioxide, then the cells will become less, and ICP goes. It's a movie only. Otherwise, how will you tell?
Associated visual.
Amrita, how will you tell the history whether it is a raised intracranial pressure headache or not?
Raised intracranial pressure.
Who's the final exam going? Final year? Final year, next exam going is who? Okay, so you tell, you people can tell. How will you tell from history?
Usually the intensity, the time of the headache, sir, it keep on increasing that intensity. From the, for example, it is initially for 1 minute, 2 minutes, that increasing of the time.
Suddenly, bolt from the blue it can come, no? Bolt from the blue also raise intracranial pressure, it can come, no?
Visual obscuration.
Absolutely correct. Visual obscuration. Understand? At the peak of headache, the headache getting increased with Valsalva maneuver, coughing, straining, nuchal pain at the peak of headache. Other things will not produce nuchal pain. Here tonsil will be, the neural are all sensitive structures. So pain, nuchal pain, we are Valsalva straining thing producing headache. What is it? Visual obscuration at the peak of headache. So they tell that, and one thing is that throbbing character, ICP headache is always not throbbing. Understand? The throbbing is something you get in migraine, vascular headache. Usually, ICP headaches are not throbbing headaches. Understand? So, other than if you tell throbbing, I will ask you what are the various types of throbbing headache. You tell now. You have to tell various types of vascular headache. You have to tell classical migraine, how it comes, complicated migraine. You have to tell about tension headache. You have to tell all autonomic cephalgia, hypnic headache. All headaches I can ask. Cluster, hypnic, tension, all migraine, classical migraine. Everything different headache. You know how it comes, which part of the area it comes, whether it has epiphora, congestion like that, they have any autonomic features, does it affect the face? Most of these headache affect everywhere, understand? So don't unnecessarily put, they are all throbbing. So if you put throbbing, you will be screwed there, man. So you should know without throbbing, you should, they have headache character something. If it is raised intracranial pressure, not that it will not produce throbbing. Normally it is, they are not throbbing. Pulsatile headache you should never tell. Throbbing pulsatile. Pulsatile throbbing headache will never come. Understand? Usually will not come. Pulsatile headache will not come for a ICP. Understand? Okay. So she underwent a surgery for headache, no? Okay. So was there any visual loss or anything? Other thing which will help you in history is whether they have any history of that double vision or something like that at the peak of not coming. Before that, you should leading question you should ask whether she had any transient. Once she told obscuration of vision or double vision sometimes. Under that. Okay, next.
Negative history, sir. No history of visual disturbance, double vision.
You have written that double vision. Yes. Okay.
No difficulty in swallowing or nasal difficulty.
You have written. How does it help you? These people are exam going.
Sir, to have a probable extent of the
No nodular swelling or pigmented patches over the body.
So this
neurofibrosis.
The which one will produce? They will produce what?
NF2 usually being associated with this vestibular traumas.
These pigmented patches occur for what? Nodular swelling, cutaneous neuromas, this caphales, what they are common for what illness? NF1 or NF1? Talk loudly, man.
One sir.
So why he has written? Why? What is the significance of that? What is the significance? Tell man. So you wanted to rule out NF1 or NF2?
Actually,
Unnecessary, you should not write no. You should ask that, what is the incidence of vestibular adenoma in NF1? Amrita. It is just like general population only. NF2 90% will produce. Or 95 can produce vestibular adenoma. NF1 incidence of a vestibular adenoma in NF1 is just like general population. And so people will ask why we ask for these patches. Immediately you people will tell that is NF1 we want to see. Not that NF2 can also produce patches. Understand? But they will not, this nodular swelling and all is very less there. But patches and there also the number criteria all, I don't think NF2 it is there. But there is some that you see, I don't know, that discoloration is that patches, there is some difference between NF2 patch and NF1 patch. You should check that. But otherwise, you should never tell we wanted to rule out NF1. NF1 you rule out, but it will not produce, it will not help you in telling it is a vestibular adenoma. Because their incidence of vestibular adenoma is as general population only. Understand? Okay, next. After that headache disappeared.
Yeah.
Headache was where actually? Headache came at what point of time?
Sir, it was like 5 years ago for 1 to 2 months she was having headache.
At that point of time, patient was having hearing loss and only hearing loss
Hearing loss was there.
and walking loud.
Hearing loss and unsteadiness was there.
But the rest of the things came after some years later.
Yes.
But seventh level has a long course. You should know whether right from the brain stem to the angle to the canal to fallopian canal like that. So you know how to pick it up. No? If hearing is involved along with seventh, it is in the canal or in the angle. So distal to that, after this cochlear thing all go, only seventh nerve can get selectively involved. So from labyrinthine segment you get onwards only 7 with after labyrinthine this clear secretion will also get another way and go. Then you have hyperacusis and taste. So below that stapedius thing they will not have other things, only peripheral facial palsy. So that history you should know very well. Seventh localization, understand? Okay. So based on this, your anatomical structures you thought was 7th nerve, 8th nerve.
Cerebral hemispheres associated with this.
So just because patient has got hearing loss and 7, it doesn't mean patient has got a lesion in the angle or anything. Understand? So it could be right, 7th and 8th could be involved from the bone only, from the cochlea or from GSP and everywhere 7th and 8th can get involved. Even seventh can get involved, even any lesion in the bone outside like that, because it has a big hole. Hearing also can get involved in the bone. Understand? Only thing which will put you is if you can get a clear history of sensory neural retrocochlear deafness, like discrimination is gone. Understand? Rollover is there. Then it will not come with the end organ. That will tell you involvement of cerebellum, involvement of sixth nerve. Usually, it can still get caught in the bone in canal, Neurolos canal, in the bone only. Yeah? But normally sixth nerve, if it is there, you can tell it is more or less in the angle only. Understand? If sixth is there, or somewhere in the brainstem. Understand? But otherwise, cerebellum will take you definitely in the angle. Otherwise, just because patient has got fifth involvement, seventh involvement, eighth involvement. Eighth means hearing involvement is there. Seventh is weakness is there, and face involved, and fifth is involved. It need not be in the angle. It could be in the middle fossa also. A Meckel scale can produce fifth. Just GSP and there can produce 7. Cochlea there can produce hearing loss. So just because a fellow has got 5, 7 and hearing loss, it doesn't mean that you should not localize to 100% to angle. Angle means you should have other evidence like cerebellum. Otherwise you should have excluded. You should be 100% sure that hearing loss is a retrocochlear hearing loss. Understand? The cerebellum is very important. Without cerebellum, sometimes cerebellum won't be involved. So you should not suddenly jump and tell my diagnosis is a CP angle. Understand? Okay. The lower cranial nerves also is normal. No? So sometimes you can have somebody with a fifth involvement. Understand? A fifth involvement there. Then 7th, 8th can get skipped. And some lower cranial nerves can get involved. Understand? So that also sometimes in the history they will have difficulty in swallowing and all. Fifth will be involved. That lesion usually is not in the angle, it is in the clivus. It's something which is creeping along the clivus because it can skip the internal auditory area but go along to jugular foramen area. Understand? Or everything can get caught outside also. In the 7th, the 7th is notorious, just lateral. Suppose something is in the jugular bulb area. Just lateral to jugular bulb, the descending 7th will go. Medial to that, you have lower cranial nerves. Understand? So these things can come. Then usually hearing will not be affected. But hearing will be affected if there is a conduction loss. Understand? So if suppose you have somebody with 7, somebody with hearing loss, it will be a conduction loss, and also 7th and the lower cranial nerves, you can tell that the lesion is somewhere in the jugular bulb area because the 7th can get involved, lower cranial nerves can get involved because they all go out. Moment the jugular vein is out, immediately medial to that is the lower cranial nerves coming down. They can all get caught there. Understand? The thing is, if 12th also is involved along with lower cranial nerves, you are most of the time 100% sure it is extracranial. Understand? Intracranial, 12th usually will not, 9th, 10th all will go. But 12th will not get caught inside that along with that. It is usually through another foramen it goes. Understand? If 12th also, if all of them come together outside, just medial outside jugular, say that there is one muscle there, right? That I will tell later. Right? That there is a bone which extends from the occipital condyle, lateral. It is called the jugular process of the occipital bone, which extends from the condyle laterally to the mastoidea. That bone is called the jugular process of the occipital bone. That forms the posterior boundary of jugular foramen. Jugular foramen posterior boundary is formed by that. There is one muscle which is getting attached there to jugular process. It comes from the transverse process of atlas. That is called rectus capitis laterally. So that muscle, very important muscle. Medial to that muscle, you get the vertebral artery. as it comes out from C1 foramen. Lateral to that you have another muscle which is posterior bilium digastric, but occipital artery comes there. Understand? Ventral to rectus capitis lateralis is what I wanted to tell. Just the jugular vein in the carotid sheath, nothing separate, is adherent only. So ventral to that muscle is jugular vein in the carotid sheath. With cranial nerve, this is there, and medial to that you get the cranial nerves coming down. 9, 10, 11, everything, 12, everything will come there. Understand? That is why everything can get caught. Understand? So depending upon what is caught, you should use your intelligence. Importantly, what I wanted to tell is hearing loss. You should be 100% sure it is not a conduction loss. Understand? Sometimes they can have a mixed loss. Understand? Both will be there. Understand? Okay. Now we will come to the clinical examination. We have reached clinical only. Okay, no problem. Okay, that's clear. Clinically we will go because I have to ask you about operative steps. That is why. Okay. So history is more important. If you can arrive at nothing more, you will get it. I will just skip that and ask you what you got. Anything extra you got after the clinical, nothing you have got. Okay, just go to the next examination point. They will ask what they will ask. Go to the next. Yeah. But that's what it is. If you think it is vestibular sarcoma, no need to tell epidermolysis, which will not produce ICP, meningioma. You can tell, but usually hearing loss will not be the initial manifestation. No? Understand? Okay, next. Now, the one which tells you what is the signature to tell it is a vestibular sarcoma is hearing loss, and it's a 7th with the days to going. That is one characteristic thing of vestibular sarcoma. Okay. So this is we leave it, yeah. Okay. So always family history is important. Understand? If there is a family history of surgery done for vestibular sarcoma, and all, you can be 100% sure that this patient also must be having a NF2. Okay, next. Next. Okay, next. What is the age of the patient? Old lives here, right? Okay, yeah. Okay. So, what important things will you look for in this patient? Do and other things.
So we fundus examination.
I have not written there. Normal, eh?
Normal.
Okay, you have written, okay. So how will you differentiate the artery from a vein in a fundus?
So pulsations we have to see.
Pulsation will tell you what?
So venous pulsations will be there. So if it's
The artery will not pulsate. Tell loudly, man.
see for the venous pulsations.
Agree, but artery won't pulsate. Huh? Arteries can also pulsate in some special circumstances, like that, aortic rehabilitation, some more hyperthyrotoxicosis. Those conditions it can pulsate. Otherwise, it won't pulsate. Okay. Next, how will you differentiate other than by looking at the artery? How will you differentiate artery from vein? This is just to find out whether you have seen the fundus. How will you differentiate the artery from a vein in a fundus? One you told about pulsation. Okay. Sometimes veins may not also pulsate. And normal veins also may not pulsate. But how will you otherwise differentiate? Amrita. Good people will immediately look into this thing and so what is the color of the artery vein? So which is more nasal side, which will cross the other. Understand? These three things, if you know, you know. Understand? Let's say one is veins are larger, paler, the other one is brighter and smaller. Arteries, they cross over the veins. They will not. Arteries are all nasal to the vein always. They all go from nasal to the other side they go. But arteries are always medial to, when they start, it is always medial to the veins. And they can cross over the veins. Veins will not cross over the artery. Smaller caliber, bright reflex, paler is vein. Some they tell some dusky red, this red and all, but this ways you can appreciate. And where is the disc seen normally? They will ask whether you have seen where is the normal disc, where is it seen? How will you measure the size of the disc? So these things you should know. And I don't think you people have your ophthalmic hospital only, you must be healthy. You should know how to examine the fundus, what is the normal size of the disc. Suppose somebody has got raised intracranial pressure, how will you tell what is the size of the swelling? So in ophthalmoscope, in how to use ophthalmoscope? You know, Amrita? Eh? We are using. We have seen, have you used? Suppose, Komal is there, all these people are there. I have to see their fundus. Understand? So he is wearing a specs, I am wearing a specs. Understand? It's always better you see when you look very close to the aperture, you see. Here both of us are wearing big magic glasses there. So in that thing, how will you go and see the fundus? You understand what I am telling? The best thing is, I am wearing a glass and patient also is wearing a glass. But to examine the fundus, ideally one should go very close without wearing glass and see. So how will I know that the patient's glass is patient is having hypermetropia or myopia? By looking at the glass, you take the glass and move like that. If the images go to the opposite side, it is myopia. If it is going to the same side, it is hypermetropia. So depending upon that, you have to change the lens. You can ask them to take the glass out and you can start from a big minus if you think it is myopia and start turning and see. Understand? If it is hypermetropia, start from the other way around. And then you can adjust that wheel lens and tell, you can adjust that thing. Adjust the patient's glass, you can adjust by just doing like this with the specs. Understand? No, you are wearing a glass, no? You are looking through a aperture, I can see everybody here, this is small. Understand? If I am looking from so much distance away, I am seeing only Amrita's face now. If I look, I can start seeing everybody. Understand? Now I can see four of you there. They just like this, very close, I am seeing. If I do like this, I am seeing only that Amrita. Understand? What does that mean? Means, you have to come very close to the aperture. Understand? So, I am having wearing glass. Ideally, I should take it out. Because if I have a refractory error, if I look through a pinhole, it will get corrected. So, you don't have to wear your glass. Understand? You don't have to wear your glass. You have to wear your glass only if you have astigmatism. Astigmatism means then you have to wear that. Otherwise, you don't have to wear the glass. You can easily remove patient's glass because you have already found out whether patient has the hypermetropic or myopic, and accordingly you can adjust the lens. Understand? Your thing through a pinhole means your refractory error will get corrected. So like that you can take out both the glasses and come close and examine the fundus. So now where is the disc you should tell, because this is asked for exam just to know whether you have seen a patient, what is a cup, what is a disc, what is the size of cup to the disc, how arteries will look like, and various stages of papilledema. And where is this macular area, color of macula, peripheral retina, how it is different from central area. This much you should read. Understand? Normally it's hard just to know whether you have examined some fellow's fundus. You know various grades of papilledema, no? So you know about optic atrophy also, no? Heard or you have seen? How will you differentiate primary from secondary optic atrophy?
Margins of disabilities, the primary will be well outlined, and in secondary optic atrophy it will be very marginal. Second, so there will be other, in the retina we can see important those.
Not early or established or chronic or fully developed papilledema. Not that early, then fully developed chronic, all three I have removed. Now it is atrophic papilledema. How will the fundus look?
So pale with not well-defined disc.
No, what is the hallmark of that? It's a sheeting of vessels, understand? Sheeting of vessels. Okay. Other important thing what you should check is this nystagmus, no? Eye movement. So, what nystagmus you expect for your diagnosis here?
So it would be either unilateral nystagmus only because of the labyrinthine segment involvement, opposite, fine nystagmus opposite to the lesion, or it could be bilateral nystagmus if the NCM is also involved, unilateral with the fine nystagmus on the opposite side, Bruns nystagmus.
So, what is Bruns nystagmus, Amrita? Amrita is under my firing range. That is, she is sitting in front of me. Yeah, you should not have sat there, no? Okay. Yeah. It always asks for exam. Right? See, told one is you have a gaze evoked. All are gaze evoked. You have a coerced nystagmus. Coerced nystagmus, which is not. The other one, vestibular nystagmus is very fine nystagmus, fast, very. This nystagmus is large amplitude coerced nystagmus, which is cerebellar nystagmus. Understand? Gaze evoked nystagmus, coerced, large amplitude. The other one is fine, small amplitude, fast. This is coerced, slow, and large amplitude. Understand? The thing is, if I am looking, if I am normally sitting here, if I look like that, I can maintain that eye position like that. Understand? But if there is something, there is something which maintains the eccentric gaze, for every human being there are some neural integrators. There are some neural integrators which maintains the eccentric gaze. Understand? So if that neural integrators become leaky, then the eye cannot hold to that position. It will slowly drift back to normal. Understand? Then suddenly again it goes back. You understand? That is the correcting thing. So I have to maintain eye in eccentric position. But if my neural integrators are leaky, that elastic forces of the eyeball will bring the eyeball back to normal. Then again it drifts back. So that is here. This cerebellar nystagmus, this coerced nystagmus. It is because the neural integrators are flocculous, nodulous. There are some other neural integrators. So they become leaky, means this eye cannot be maintained in eccentric position. So they have this nystagmus which will beat towards the side. Understand? Coerced nystagmus, which are not very fast, because this slowly drifts back, then it goes like that. Understand? As opposed to a vestibular nystagmus. Vestibular nystagmus, you told, is a fine, fast nystagmus and a small amplitude. It beats away from the affected ear. Away from if this labyrinth is affected, it beats away to the opposite side. Understand? So the thing is, you have a nystagmus when you look to the other side. That is grade 1 nystagmus. Understand? You have another nystagmus, you have it in your central position. That is grade 2. And even if you look to the side of the affected ear, then again it is beating towards the opposite ear. That is grade 3. Understand? That are the various stages of vestibular nystagmus. Understand? One is in this side of fast component, then primary position. Primary position also it is beating to the that side, the opposite side. Even if you look to the affected ear also, it is beating to the, that is grade 3. As opposed to a cerebellar nystagmus, it will beat to the side only. Understand? Okay. So that you should know. That is Bruns nystagmus. If you have a combination of that, do you call it Bruns nystagmus? They will ask everything. Okay. So third nerve is normal, no? Okay. Third nerve, so many things to be taught, but we cannot cover everything. Okay. So every jaw there is normal, no?
Yeah, fixed cranial nerve is also normal.
So what is the condition where you should check for your jaw jerk always? And one common illness you always treat here. what is that illness? Here, George Canal, nobody checks George Canal for a CT English. It has no significance. Understand? So, the illness for which you should test George is cervical spondylosis. Understand? If in cervical spondylosis, if George is exaggerated, means what will happen? Namrata, your name is Namrata. Now outside her range, what is your inference? It is not cervical spondylosis. Understand? It's the only time you check for a George case in cervical spondylosis, George will never get exaggerated. If it is George case exaggerated, it is a signature that you are not dealing with. Because you have so many demyelinating illness, ALS, so many things which go above, eye, brainstem above, where this thing will get exaggerated. So this is, that is the only thing. If it is cervical myelopathy, other fellows will also have myelopathy. Understand? So if a myelopathic fellow has got exaggerated George, you know you are not dealing with cervical spondylosis. Otherwise, unnecessary, you don't give a stick and get beating. They will ask about afferent, efferent, everything of George. Can you get fooled there? Understand? Okay. Okay. Next case, it is not cranial, it is spinal only. No? Then I can take you there also. I have another half an hour to tell everything about this thing. Okay. Oh, okay. We just tell me about how will you test for eighth nerve and how will you test for vestibular nerve? Hearing nerves, you tell. Go back. Taste decreased, sensation you have written. Okay, I just wanted to know whether you have tested sensation. Okay, you should check that because that sensation everybody omits actually. You have written that, very good. Swimmers, you have written 10 millimeter. It is written in millimeter only. I don't know. I don't know. This first time, millimeter. Okay, next. You do it or it is just, you do it religiously or it is non-religiously you do, no? Okay, now this is what is more important, man. So they tell me what is happening. Renis is positive both here. One Reni is diminished Reni, no? Reduced Reni on left side, no?
Yes. Reduced absolute wall conduction on the left side, sir. In bilateral air conduction is more than 1.
But that is reduced Reni. But ABC is also reduced. So what is your inference? Weaver, you have not written.
Oh, sir, I have done it.
Forget. There's no sorry. If you do something and you kill a patient and you tell sorry, it has no value. So examination you should tell about Weaver. Why it is important, I will tell you. No, I will tell you. Now you are in my firing range. So you are stone deaf. You have unfortunately you have a nerve deafness. You have nerve deafness. You are totally, you cannot hear anything. You want tuning fork, you do what you get. You can tell.
Sir, for the hearing we can use either.
No, what these tuning fork tests, what is your inference? I am stone deaf here, man. I cannot hear anything. So if you do this tuning fork test, what will inference will you get? I will not waste time. So you do here, it will say you do this bone here. Patient will tell that he is hearing because it is the opposite side. But you keep it here, they will not hear. So you call it Reni negative, but it is a false negative Reni. So if anybody is, because sensory neural fellows can be stone deaf, understand? As opposed to a conduction fellow. Conduction fellows will hardly be ever stone deaf. Understand? So if a stone deaf fellow, they are not hearing anything, you keep here. They said they are hearing, they are perceiving that thing. It is they are perceiving through the opposite ear. Right? So that is false negative Reni. You should be aware of that. Understand? Okay. Vestibular, what are the various tests you will do?
Sir, pursuits.
These are all nonsense. What you should do is, Say you start walking, Fukuda, then rhombox and head thrusters. These 4 tests you should do. Understand? Bedside, these are all bedside tests. You can do. You start walking. Understand? Just march also. This march is, vestibular fellow will turn to that side. That how much they turn, something is there, you should know. And they go back and forward also, they start circle, they will again, they start walking. Fukuda, it is available, you should see that. When it asks them to close the eyes and do like this, they start rotating like that. And they can march also. Then also they start walking. Then also they keep on turning. And then rhombox, they fall to the side. Understand? They fall to one side only. Understand? If you turn like patient like that, they fall here like that, rhombox. Then I had thrust test, THRUST. That you know what it is?
Yes.
What is that?
Sir, you will stand in front of the patient and tell him to look at your nose, and then after that suddenly you will turn the face of the patient. So if he is to the side, so if he is still looking at the nose, that means vestibular component is normal, sir.
If it is not you are female, so I cannot do on 1 minute. I will show you one of you, it is very important. Let's come. You people exam doing, I will demonstrate on that. So I am asking him to look at my nose. Understand? I am asking him to fix on my nose. Understand? You keep on looking here. Disease is affected here. Understand? So I say if it is not affected also, if it is not affected, if I turn quickly, he will still be able to look at my nose. Understand? If I do this side also, however, it has to be done very fast. First you see that he doesn't have cervical dislocations. Understand? Otherwise you will have to carry him afterwards. So you suddenly ask, catch the hand and ask him to keep on looking here. A fellow with normal vestibular function will be able to look there. Suppose this is affected. If I am turning it fast, his eye will go and then come back. That is called catch-up saccade. That will be seen in most of the cases, bedside test. When you are peripheral vestibular, you will be able to see that. So that is one of the things you should say. Catch-up saccade, star walking, march, Fukuda, other things you have, your rhombox, C4 you should test. Right? Okay, examination. Okay. Simple test, very simple bedside. Next. Keep on moving. Yeah.
Sir, other lower cranial nerves are normal, sir.
Very important for me, man. Very, very important for me. So, 9th, how did you test?
Sir, uvula will see is it central, and then we can see the gag reflex, sir.
9th, how did you test? 9th is sensation, posterior pharyngeal wall.
Yeah.
Sometimes you have some lowering of the that you can see. That you sometimes you can notice, otherwise sensation only. Other things, 10 important for neurosurgeon, I will tell you. 10 that is post-op only. Post-op, the 10 they will finish here, so that I don't have to ask after. So after surgery, your patient has got stridor. After you have done a very good surgery, you have not even looked at the 10th nerve. You have done a neat surgery, but after that patient is having some stridor problem. So anesthetist is telling you have fiddled with the 10th nerve. You are telling we have not done anything. It is your headache, you have done something. So what they have done is, their overinflated tube can sometimes compress the recurrent laryngeal nerve. Recurrent laryngeal nerve in the bare area. So after surgery they can have transient recurrent laryngeal nerve paralysis. So all the intrinsic muscles of the larynx are supplied by recurrent laryngeal nerve except one nerve, that is cricothyroid, which is supplied by the superior laryngeal nerve. That is, external branch of the superior laryngeal nerve. Understand? What did I tell Amrita? Something I
all the muscles of the
intrinsic muscles of the larynx
are supplied by recurrent laryngeal nerve, except for the cricothyroid supplied by the
superior laryngeal nerve. Understand? So if suppose recurrent laryngeal nerve is involved only, superior laryngeal nerve still is intact. Superior laryngeal nerve supplies one muscle, which is the cricothyroid. Cricothyroid is the is a tensor of the cord. It adducts the cord. Understand? Suppose if recurrent laryngeal nerve is involved, so after surgery, a patient is having stridor, you are very much disturbed. So you do a indirect laryngoscopy or laryngoscopy that they do. So if the vocal cord is in not adducted paramedian position, you are not at fault, because your recurrent laryngeal nerve is gone. Understand? Because it is in paramedian position. Suppose in a lateral position means your vagus has gone. Understand? That is both superior laryngeal and recurrent. That goes in our 9th, 10th fiddling. So you just by looking at that is what is very important. All the intrinsic muscle. What is abductor of the vocal cord? Only one abductor, lateral. Very good. All others are adductors. So what is Wegener-Grossman theory? Wegener-Grossman theory is, if there is no cricoarytenoid joint problem, understand? A paramedian location of the cord is always due to affection of recurrent laryngeal nerve. Understand? You don't have to know that, but at least after surgery, patient has some problem. You don't know whether it is from our manipulation or from anesthesia problem. Okay. So tongue also, I just want to ask you. 11th also, just tell me. What will happen if what the things you look for in a patient until 11th is affected? Suppose my 11th sternum is affected. Amrita here. My sternum of right side is affected. What will happen? Well, looking only, not training going.
Yes. Opposite side turning will be affected.
By looking you should tell. You didn't get. Okay. You are not asking, you are just looking at the patient. Understand? So you look at the patient and then tell, oh, this fellow's sternum is affected. So how will you tell that? Because turning, you cannot ask the patient to turn. I told.
Deformity will be there, sir.
What is that?
Asymmetry will be there, there will be contraction of the opposite.
I am wearing very big shirt like that. I am wearing a big shirt. You cannot see my sternum. Actually, sternum, this sternum, it rotates the head to the other side. It also flexes the head to same side. So they will have a tilt to the normal side. That you look at that and tell, like a child is, a posterior fossa child is sitting with you. The tumor is there. You are entering a ward and there is 3 children are sitting. One is a medulloblastoma, one is a ependymoma, one is a astrocytoma. All the 3 is sitting. By looking at them, some findings are there. You can tell that this is a medulloblastoma, this is a ependymoma. What are those findings? Amrita, all 3 children are sitting there. 3 children, you are telling all these 3 have got tumors. One is a astrocytoma, one is a ependymoma, one is a. So how will you tell? This may not be there, but some gimmicks for that. Understand? That is, say, medulloblastoma, this 4th nerve crosses in the superior medullary velum. So if it arises there, the 4th nerve can get caught. So they will have torticollis. They will have, their head will go to the opposite side. Chin will look at the same side to avoid double vision. So kid, suppose this 4th is affected, they will be sitting like this only. So a child who has got, among that, a child who has got torticollis, you can tell this fellow must be having a, and medulloblastoma kids are all very handsome kids, you have seen. Unfortunately, all the kids are handsome, no? So they have medulloblastoma. A child who has got, the other one arises from the floor of the fourth ventricle. Which one? Ependymoma. So if floor goes, if seventh comes with sixth, eye is gone, seventh is also affected, eye is inwardly like that. This all we are telling have got posterior fossa tumor. So patient likely will have ependymoma. The third fellow who doesn't have anything, or only may have some ataxia or something, that fellow is arthrocytoma. This is just jokes only, just gimmicks to tell. Understand? So, what is more important? 11th we told. How will you check for 12th? The other thing is shoulder. That is all you shoulder rotation, like that. More things I wanted to tell, because supratentorially, if one hemisphere is involved, your supratentorially, your sternum-mastoid, all the cranial nerve nuclei, nuclei will get supply from both hemispheres. Understand? Both hemispheres. More from the contralateral hemisphere. Ipsilateral representation is minimal. But all the cranial nerve nuclei, except seventh and all, I don't have to teach. Most of the cranial nerve nuclei, they get representation from bilateral hemisphere, but mostly from the contralateral. But there are some cranial nerve nuclei which can get sometimes only from the contralateral nuclei. That is all the motor nuclei, like the nucleus to the hypoglossal, nucleus to the sternomastoid, nucleus for trapezius. They all can get supply only from one hemisphere. So how is the supratentorial, this hemisphere representation for sternomastoid and trapezius? Am I confusing you so much? Because it has a reference to the patient. Trapezius, everything representation has to come to the nucleus. From nucleus onwards, it is what you call your element, something like that. So the nucleus for the 11th, it is all we call ambiguous, but the sternomastoid part of that, it gets representation mostly from, if it is to be from one nucleus, one hemisphere, it always comes from the ipsilateral hemisphere. It is not coming from the contralateral. Understand? So, because it comes down, crosses, recrosses. So, supranuclear representation of sternomastoid is always, if it has to be from one hemisphere, it is always from ipsilateral hemisphere, as opposed to trapezius, it is always from the contralateral hemisphere. So suppose I have got only unilateral representation. By one side, trapezius nucleus and nucleus for sternomastoid is affected. Understand? So if I have one hemisphere lesion here, this hemisphere is affected. So what will happen? My opposite trapezius will go. Ipsilateral?
Yes, yes.
Understand? So the thing is, your head will look to the affected trapezius like that. Understand? You remember like that. If the head, because this side sternomastoid is gone. Understand? If this side sternomastoid goes, means he will not be able to turn to the opposite side. Understand? So sternomastoid will get affected on this side patient will not be able to look at the affected shoulder, because that side trapezius will go. Like that, once it has crossed, it can all turn. Understand? But that is all you should see. How will you look for winging of scapula from accessory involvement, trapezius involvement? Because serratus anterior, only on this winging will come. Trapezius winging medially will come even at rest, medially. Understand? So winging at rest is suggestive of trapezius involvement. Understand? The other one wings posteriorly and laterally. Here it wings medially. Understand? Okay, and 12th cranial nerve, what will happen? If it is affected, you push the tongue out because of the opposite genioglossus. This, if my right 12th goes, it will come to the same side. Understand? It will come to the, so agreed. So That is because of the opposite genial clause. So suppose it is inside, what will happen to tongue? It will come. If it is go like that. Inside the mouth, what will happen? What opposite? Inside the mouth, is inside the mouth. Which I will be able to do. Understand? Inside the mouth, here you cannot take to the opposite side because the genial clause is pulling here. Inside the mouth, they will not be able to do. Other side, they will be very strong. You understand? I understand. If ipsilateral intrinsic muscles have gone inside the mouth, it will be difficult for them to. She is testing. You put your finger and test. Always when you check that, you ask the patient to do that and pulsate. Understand? So 12th is very important. Okay, now next.
So motor system examination was normal, but almost came. It was a broad-based case and she was able to walk with 1% support, and Rombox could not be assessed because of severe imbalance. Other signs were normal.
Okay. This is all the point I want to make is that suppose you have three cerebellum. Understand? One is archicerebellum, which is your flocculonodular lobe. Paleo is your anterior lobe, and you have neocerebellum, which is your lobes. And otherwise you classify like midline, vermis. Then you have paravermin area, which is more important for all these findings. And then you have the hemisphere. It is paravermis area, which is more for all your these findings. It's not that lateral hemisphere. Right? The point which I have to tell is, if floccular, nodular lobe, all the three will produce ataxia, severe ataxia. Floccular, nodular lobe fellow, moment you make him sit or lie down, he has no ataxia. Because they have, because of this vestibulum is affected, the moment you fix the fellow and all ask him to sit, he can do everything. Even this heel, sin, everything a floccular, nodular fellow will do. If he has an anterior lobe involvement fellow, they may still do this, okay, but they will not do heel sit. So like that, other fellows, if both goes means it is more para. This you should check. Otherwise, we have talked about nystagmus also. Okay. What about reflexes you told? Okay. Okay, if I can ask one question before we go for next slide, quickly.
So
Nothing, you have not got anything, man. Next extra. Okay, just keep it there before. No problem, because other madam's class is at what time? Plenty of time. I just don't want lunch or anything. Just I will take them through this thing. What I wanted to ask is, what is Babinski sign? Babinski store sign. Amrita, what is?
Babinski is classically elicited by.
No, eliciting, various ways you can elicit. Original Babinski sign is a toe sign, understand? You don't call Babinski positive or anything. If it is upgoing, you call Babinski sign. There is no negative Babinski. That every fellow knows. Tell me another 5 more Babinski signs.
Malleolus, shin.
No. That is various ways of eliciting a toe response. That is not. Babinski has described that. My thing is other 5 more Babinski signs are there.
So responses.
I will take Komal's degree back. Komal has to surrender the degree. Yeah.
Extension, withdrawal.
No. That is all. I am talking of other 5 Babinski. And Babinski was a student of Charcot. He had 3 fantastic students. One eccentric student was this Joseph Babinski. He described so many signs. Other is, the one condition which is important for neurosurgeon is, it is called Babinski 2 sign. That is, hemifacial spasm. They contract, In that contraction time, eyebrow, normally eye contracts, your eyebrow will come down. In the synkinetic movement which occur with hemifacial spasm, during that eye contraction, eyebrow will go up. That is called Babinski 2 sign. Very classical sign described by Babinski. In hemifacial spasm, when the eye contracts, instead of the eyebrow coming down, eye goes up. It is an involuntary movement. Understand? That is one of the Babinski signs. Why it is important? There is another condition called where eye closes. It is like winking at girls. Understand? That is not. You wink at girls and blepharospasm. What is the difference? Amrita. Winking at girls you do with one eye only. The other one you do with both eyes. So blepharospasm blepharospasm is bilateral. Blepharospasm, eyebrow will come down. Understand? It will not go up. That is how you differentiate a blepharospasm from hemifacial spasm. And it is bilateral. Third is, some myasthenic people. Myasthenic people, they develop towards the evening some drooping of the eyelid. So those people, they do this, eyebrow will go up. That is, their frontalis there, because to see they will take the eyebrow up. They are not Babinski signs. This is eyebrow. But what are the other two Babinski signs I have told? Third Babinski sign is, say if I have a hemiparesis on one side, you ask the patient, blow and all, the opposite platysma will become very, it will stand out. That is one of the Babinski signs. Other Babinski sign is, any fellow ask the patient to keep the hands like that, and you ask the patient to extend like that, their affected hip will come out of the coat. Understand? And third thing is, Babinski, another thing Babinski describes is from this functional to true sciatica. Some people will tell they have pain and all. So what Babinski has described is, it is an old thing. Now it will look foolish. Babinski described that real sciatic fellows, they can have a sluggish angle there. That is also described by Babinski. That is this functional. Now this what is that? People who don't have, they for compensation purpose they will tell that they have got pain. So Babinski described that if that fellow, you check for your angle, if you see a sluggish angle, that fellow has true problem. So one is that thing, other is platysma, other is this weakness, other is Babinski saying this hemifacial spasm. Then there is another called, neurogenic claudication, vascular claudication. There is a spinal cord claudication also. That is, neurogenic, vasogenic, all of us know. It is related to our chorda equina or because of our peripheral vascular disease. Cord, then you make the patient walk because of then they can have cord problem, ischemia. So you make the patient walk, their spasticity can increase. So that is also described by, and they check the patient after walking, the spasticity increase. It is called again a Babinski sign. I think some afternoon Babinski or something it is called. So Babinski is a great fellow. He has described so many tests. So this is the investigation. One quick question to you. Why did you ask for MRI? This present day CT scan is very good. Everything you can see with that. Everything. So why here very difficult for patient to lie down. Always, what investigations you do, you think always you should check, you will do all of this auditory function tests. That is important. What type of deafness, how much hearing, that should automatically come. Understand? And so why you did this investigation? Why you could have done a 256 live CT scan, which will give every information. So what information you got extra from this? I will waste time. I will tell it is pile breathing, which is very important for a surgeon. Understand? That information you get only from this one. Other important information which you get is, if it is a very small or large tumor where hearing is preserved, the intensity of labyrinthine fluids, if it is T2 hypo or flare hyper, then even if they have hearing, they are very unlikely their hearing will get sustained after a hearing preserving surgery. So that information you will not get with the CT scan. CT scan is good to see emissary foramen, jugular bulb, mastoid air cells. There's so many information which this thing doesn't give. It will give, they are complementary, but this is the best investigation. Every information you get, including labyrinthine fluids, pile breaching. So this is the most important investigation. Okay. So you have a CT, you don't have a CT scan. No? So here there is only one diagnosis. No? So now the next question. What is the prevalence of vestibular sarcoma? You will be surprised. Present epidemiological studies state that it is 1 in 500 people. It is that common. And you know the incidence of, when myself, Timmappa all studies, it was 1 to 2 per 100,000 patient years. Now it is 5 per 100,000. It has come in the last 3-4 decades because of this MRI. Everybody is getting left and right, getting investigated for non-specific symptoms. Some people will have headache, migraine. Everybody sends for in abroad and all, they have strict protocols for doing MR. Here everybody sends, and you pick up rate for vestibular, incidental vestibular. It is not symptomatic. Incidental vestibular sarcoma has gone up like anything. In people over the age of 70 years, they have found that it is 20 cases per 100,000 patient years. So many of the oldies, they have a very small vestibular sarcoma in the internal auditory canal. Doesn't mean they have to be treated, but the pickup has become so much. Otherwise, you know, only if people, which are the group of patients who should go for MRI scan, is patients who have unilateral hearing loss. If there is a difference between the two, intraoral difference between the 2 ears is more than 15 decibel for one frequency, or more than 10 decibel for two contiguous frequencies, they are the people who should go for screening. Otherwise, there is no role for screening. If unilaterally, if they have this differences between 2 ears, you should go for screening. Even if you have patients like that, you send for the screening. 100 patients with unilateral deafness, you send for hearing loss, not deafness. You send for the screening, only some 1 to 5% will still have only a vestibular sarcoma. Others they don't have. So the point which I am taking, in the era when we all studied, many of the patients have lived their lives and died also without ever having found out they are having vestibular sarcoma. Because they would have lived their lives without having even 3-4 centimeter vestibular sarcoma, they would have lived their lives, died at the age of 80, 90. Now, with this incidental thing, they are prone to get treatment which may not be warranted. Understand? Small vestibular sarcomas will be seen. You should not chase that. Suppose you have a 70-year-old, I am going to be 70, Simappa. So if I have a vestibular sarcoma 70 years, I am going to Amrita, what will you do? I am asymptomatic. It is intracanalicular.
I will wait, sir. We can repeat the imaging and see if the rate of growth will matter.
Correct. One you wait to see whether the tumor is growing. But otherwise also, I have normal hearing. Now I have got normal hearing. So also you should do proper hearing studies. Because what has come is, if we have an intracanalicular vestibular sarcoma which is absolutely a normal patient, doesn't have any symptom, you can wait and screen and do every 6 months MRI to see what is happening, or do hearing test. If hearing starts dipping, what will you do? I want my hearing, because I told binaural hearing is there for us to survive. If I have a malfunctioning here. It is not tough. This ear is not working properly means this, my poorer hearing ear will always affect function of my good hearing ear. Understand? That is why if my hearing starts dipping, I know my other ear also will not work properly. So you want to treat. So that point of time, small lesions, elderly, you can send them for not surgery, for gamma knife, because surgical outcome you compare for canalicular with gamma knife is still better. Understand? Still better, because I am a surgeon, because their data is far better. Both are not sustainable, durable, but till we go to grave till 80 years, I can still have some hearing with gamma knife. Understand? So if I have you have got Amrita, you have got gamma knife and all private gamma knife, everything is there. And you are working somewhere, you have got everything. I have got a vestibular sternoma, intracanalicular. I am deaf. What will you do?
How big is the vision?
That is intracanalicular.
That intracanalicular vision. But surgery you can avoid it, we can sacrifice. But
Okay, you can
because of your comorbidities, how?
No, I am deaf already. Deaf intracanalicular sternoma doesn't require any treatment, because there is no way you cannot improve the hearing. Also, you can again 100%, you can wait. No need for gamma knife or anything. But if you have a canalicular sternoma which is dipping in hearing, that point of time you can offer gamma knife to surgery. Understand? So other thing is, we will come to this. Now we have to operate. Before that, what operation do you do here? Retrosigmoid. Mastoid you should not tell, retrosigmoid. Understand? Because sigmoid sinus is all in the mastoid bone only. So to see the sigmoid edge, you have to do mastoid drilling. Understand? So retromastoid you do. Okay. So what are the other approaches?
Sir, it can be translabyrinthine and middle.
Okay, translabyrinthine. So which case you do middle cranial fossa?
Sir, if there is hearing is preserved.
If hearing is preserved, small intracanalicular, people do. We don't do, but people in US and all, house clinic and all, they do. Or many other places they do a middle fossa approach. So middle fossa approach, how do you know, say if the tumor, which nerve it arises, from the inferior vestibular nerve or superior vestibular nerve? Amrita. Say this vestibular sternoma is arising from one of the vestibular nerve. Unfortunately, there are two vestibular nerves. One is an inferior vestibular nerve, other is a superior vestibular nerve. So which nerve it arises? It can arise from both the nerves. So the point I am making is, if you have a canalicular vestibular sternoma and you want to preserve hearing, and it is arising from the inferior vestibular nerve, you are going through a middle fossa approach. You have to work below the seventh nerve to get into that tumor. Understand? By that time you do surgery, you may preserve hearing, but your seventh nerve is at risk. You understand? So a middle fossa approach you do for a vestibular sternoma which is arising from inferior vestibular nerve, seventh nerve is at risk. So if it is arising from superior vestibular nerve, it is good, intracanalicular. So Amrita, how will you find out before surgery whether it is arising from superior vestibular nerve or inferior vestibular nerve? There is something called electrodystagmography. If electrodystagmography, if it is normal, it is arising from inferior vestibular nerve. Understand? Because that thing is going from the superior vestibular nerve. If it is arising from the inferior vestibular nerve, this thing will still work. If the electroencephalogram it is not coming, then it could be it could be from any of the nerves. Understand? If it is present, culprit is inferior vestibular. If it is absent, it could be from either. So there are some ways to find out also from which nerve it is arising. Now translabyrinthine approach, when will you do?
Hearing is already lost.
Hearing is already lost. Very good. Okay. So what is the advantages you get? you can get into the seventh nerve early. So you are doing a labyrinthine approach. So what is the key landmarks for entering there? Key landmarks. Key landmarks, there is, supranastoid crest, there is a small bone which is called the spine of Henle. You go 1.5 centimeter down, you get into the antrum, you can see the lateral semicircular canal, which will lead you to the seventh nerve. Understand? The tympanic segment, and after that, underneath the lateral semicircular canal, you can trace the seventh nerve. So how will you find out the lie of internal, in the transmastoid, translabyrinthine approach, lie of the internal auditory canal you should find in the pre-sigmoid area. How will you find out what is Sitterli's angle? Sitterli's angle you have heard. Say middle fossa dura and sigmoid sinus, it makes an angle. It is called the Sitterli angle. So that angle you draw a line from the ambula of superior vestibular, and that superior vestibular canal nerve is the lateral semicircular canal, superior semicircular canal ambula. You draw a line to Sitterli angle. That is the correct lie of internal auditory canal. Then you drill there, you can trace the nerve and go there. Right? And now coming to this approach, man, this is the main important approach for us. How do you position your patient? So tell me what position of the neck will you give?
So neck will be turned to the other, like opposite side, and will be tilted towards the ground, 10 to 20 degrees, and towards the contralateral shoulder, 10 to 15 degrees.
So tell me, why do you want to do all these maneuvers? So one is, you do max, you give flexion, then you give tilt to the opposite side, then you also rotate to the contralateral side down. So why do you want to do all these maneuvers?
So first to increase the space.
The space means, your shoulder you are pulling down, no? You are operating from this side. You are pulling this shoulder down to get this area. Now one is this one, other is this one, other is this one. You understand? Patient is lying like this. One you are pulling the shoulder down so that you get this space. Now you are rotating like that. You are lateral flexing and you are flexing. Why you do all these three maneuvers?
To minimize.
Here, now let me see you are all neurosurgery residents, okay? For neurosurgery, you tell now. Ladies get preference to questions also. But here, why, because you start from 10 marks above them. Because, you have to delete those marks, that is why. So why do you do this one? To open foramen magnum, large humans, understand? Contralateral rotation is to see the posterior petrous surface, because these days, you have this table which can be rotated. So you don't have to actually rotate too much. And lateral flexion, because mastoid should come to the topmost part, you are very close to the tent like that. So you have to higher tumors which are extending higher up. It is easy for you to go. So all these maneuvers you should do. Understand? And you put the patient on clamp only,
Yes, sir.
What clamp you use, man? You use Sugita clamp, no questions can be asked after that. Have you seen Mayfield clamp?
Yes.
Have you seen, or you don't have Mayfields?
Yes, sir.
Here you see Mayfields.
Yes.
Both, sir.
How will you fix a clamp?
So two pins on the contralateral side and single pin on the side of the lead.
So if I have to this way, I will demonstrate one of them. Okay, come. Don't sorry, man, you are beginning to get. Okay, so I am operating on this person. So your two will come here. Here the contralateral side.
Yes.
And single pin will come. So I am putting pin like that. This is okay, man. I am operating here, this side. So 2 pin I am putting here, 1 pin I am putting here. Is it okay? So why it is not okay?
Because the center of the head should be maintained.
Center of the patient center I cannot change, man. No? He has only one center, no? So how I can maintain that? You told correctly, man. The thing is, these two pins I have made, you draw a line between those two pins. Understand? So these two pins I am putting here, somewhere here. So I am maintaining you draw a line between these two pins. Understand? You find the midpoint of that. Midpoint of that. And the single pin I have put here. So you draw a line from that to the midpoint. That should cross the equator of the skull. That is what probably told. Center. If it is not crossing the equator, your clamp can slip. You squeeze the head only, may not slip. Okay. So that is important. And what type of incision you give? You are also neurosurgeon. That?
Yeah, natural patient.
Okay. Okay. So what is the other thing? What incision will you give? Incision.
Lazy S incision.
Eh? What incision?
A lazy S incision we can do.
But lazy as you are showing something else. You are telling lazy and showing some.
Lazy S incision.
Okay. What incision you give there, man? So there were so many incisions. You can give a straight incision. You can give a C-shaped incision. You can give a curvy linear incision. So you can make that is a reverse C like that. You can make a flap like that and take it. It's called curvy linear. You can make a lacy S, you can keep a C, you can make a J, you can make a horseshoe. So many incisions have come. Understand? Why do you want to do lacy S incision?
Sir, if we want to harvest the pericranium graft for the dura closer.
That you can take from any incision.
If we work to extend down up to 4
All the incisions you can go down, man. Okay, lazy S incision. The biggest advantage is you can put the retractor like that. The other thing, if you put the retractor, it will occupy a big space. Already you are working from a depth there. Here you put the retractor, everything is you are straight at the board. Understand? And then your chances of damaging the vertebral artery is very minimal. So how do you make that incision, Amrita?
So the center point of the incision we take it as where we have taken the transverse sigmoid junction. Depending on how large the tumor is and how upward.
They are all, do you play football? All just dribbling only, not arriving at the answer. You should hit goals only. So before that, what is the landmark of transverse sinus and what is the surface landmark of sigmoid sinus? How many people can tell?
External occipital protuberance to this meatus cell, this will be transverse sinus.
What is that?
External occipital protuberance
So,
to
root of the zygoma. Root of the zygoma to the, it's called Frankfurt line. So that is, say you can tell the lateral two-third or that medial two-third of that will be transverse sinus. Understand? And then mastoid. What is asterion? Then I will come to sigmoid sinus. Asterion is what? This girl. Namrata. Asterion is the meeting point of three sutures: parieto-mastoid, occipito-mastoid, and lambdoid. Understand? And so that is the meeting point. Usually, this transverse sigmoid junction will be either there or just below that thing. You can roughly tell that it is somewhere there. But most importantly, there is another suture called the squamosal suture. Squamosal suture meets the parieto-mastoid suture. Then parieto-mastoid suture comes and joins all lambdoid, occipit. The parieto-mastoid suture is a horizontal suture. That is squamosal suture will meet parieto-mastoid. The anterior, that meeting point of parieto-mastoid and squamosal suture is always anterior to the anterior part of transverse sigmoid junction. Understand? So many drilling, they start drilling there. Understand? Parieto-mastoid suture, that beginning, transverse, squamosal suture, parieto-mastoid suture. Parieto-mastoid suture is always, that beginning point is always anterior to anterior part of transverse sigmoid junction. So you can start drilling from there if you have to expose the sigmoid sinus. And from that point, that transverse parieto-mastoid and squamous cell suture point to tip of the mastoid is the lie of sigmoid sinus. Understand? Okay, this is just to tell you if anybody asks what is the surface landmark. Okay, so from where we drifted, incision. So all sorts of incision are there. So you can do a small thing. How will you make this lazy as incision? I will guinea pig, again from guinea pig I will tell. This is very important for your life. When you go and do private practice, who is the first year fellow here?
Close to first years.
Who you are first year? You come, because you are in it here. You have to know. This is very you have no hairline, man. You have lucky fellow. Okay. So first thing I am checking is this. What is this one I am taking? Angle of the mandible. So just draw a line from there, angle of the mandible. Approximately you should know where the angle of the mandible is. Approximately. Understand? Yes. Approximately angle of the mandible. You are drawing a horizontal line like that. Nothing to do with this is just to know. This he has got angle of mandible. Right? There is a line here. Okay. Then you have I am palpating something here. This is the tip of the mastoid process. Then there is something called the midline. Understand? That midline you draw like that and bring to this line here. Understand? The midline. Then between the tip of the mastoid process and this line, you come to the midline. That one, tip of the mastoid process to this line, midline, you should find the midpoint. That midpoint you extend down to this line. So I have confused so much, So you tell. Following me, first, I want to know the angle of mandible level. Then, I am finding the midline and mastoid. And then I want to find the midpoint of that. The mastoid tip to midline. Midline is there, mastoid tip, draw a line like that. You find the midpoint of that. And take that midpoint thing, I want to know where it is coming to. Here. Yeah. So there you have to mark like that. And now you put one finger but bring like that so that the lower end of the incision should come there. Can you understand what I have said?
Yes,
so you make a incision, one finger but incision medial to the mastoid groove, and the lower end of the incision should be down to a point midway between the mastoid process and midline in line with the angle of the mandible. Everything you got in one sentence. Tell. You can tell.
The incision is made about one finger breadth medial to the mastoid notch and
mastoid groove,
mastoid groove, sorry, tip of the and the lower end of the incision should be drawn to a point which is about midway between the midline and the tip of the mastoid at the level of the angle of the mandible.
Good, very good. Okay. That is the incision. Okay. So after that you do everything. So the other case will take it like a short case, don't worry. Okay, no, I have time, don't worry. Because the other madam who came here should not get offended. Okay. So surgery, you want me to teach surgical steps or leave it like that?
Please.
Huh?
Yes, sir.
Okay. So you are putting like that, you are doing a proper craniotomy or craniectomy. Key thing is you have to expose the transverse sigmoid junction. Understand? Key thing. And you can, other thing is, you should not avoid you should not cut too much down to avoid, you should avoid cutting the vertebral artery, which can occasionally come. So how you avoid vertebral artery is, there is one is superior nuchal line. Below that there is another line called the inferior nuchal line. You can palpate. Inferior nuchal line, medially it is horizontal. Laterally it is vertical. Understand? Inferior nuchal line, you palpate, you take a skull, inferior nuchal line, medially it is horizontal, laterally it dips down. Understand? So you should never go below the vertical limb of inferior nuchal line, which always, that is, any incision is okay. Understand? You can always put your finger and palpate for this. There is this vertical limb. is a ridge actually, you can feel that. So you should, your incision, you should never cut below that. If you cut below that, vertebral artery will come. Understand? So your inferior lateral limb of the inferior nuchal line, because all this your superior oblique muscle is attached above the horizontal limb. Your other inferior oblique, rectus, capitis, major, those things are all in below the horizontal limb of inferior nuchal line. Here above that superior oblique muscle will go. But all the muscles are there, but you can palpate and see. So your incision is like that. Whichever incision you make, you should. There is no need for CP angle acoustic surgery to expose that, because this is only for large tumors. If you have to go to foramen magnum area, only you need make this large incision. Otherwise, no need. And before we go to surgery, just to tell you, what is this far lateral, extreme lateral approaches? Far lateral approach, you know, you have to expose the vertebral artery that it comes out from the groove of C1. But you are not exposing out of the groove. So you are working still behind the vertebral artery. You work behind the vertebral artery, you are exposing the vertebral artery over the C1. You can take it out if you want, you are exposing the vertebral artery but not taking it out of the groove. But you can, still with that you may be able to drill the condyle even without exposed. If you take the vertebral artery out of the groove, you call it extreme lateral, because you are working in front of the vertebral artery. Then you call extreme lateral. That is one. Other one is extended far lateral. It is extended far lateral is what I told you. It is, you know, you are working through the condylar triangle, which is formed by this superior oblique and this rectus capitis lateralis. That also you work there means you are reaching the lateral half of the condyle. You reach the other part of the condyle you can expose with your. So when you have to do, we say in foramen magnum lesions, what you want to do, if you have to do, is you remove the posterior medial 1/3. It is not the posterior lateral 1/3. It is the occipital condyle is lying like this only. It is actually, you have the equator of the foramen magnum. Where do you get the condyle? Which clock position you get? Occipital condyle is lying where? The occipital condyle is actually it is in front of the equator. It is actually not behind the equator. Understand? Condyle is not behind. It is actually in front. So you have to remove the posterior medial 1/3 of the condyle to go to foramen magnum. If at all you have to remove. If you have to remove the posterior lateral part of the condyle, which you have to expose for jugular foramen, then only you use the other extended far lateral. So we drifted away. So this patient is positioned like that and you are operating. How will you start operation? You have done exposed everything. Dura, how do you open dura? The most important is to expose the transverse sigmoid junction. You have to take the first burr hole 1 to 1.5 centimeter lateral to the posterior. Understand? Lateral to the posterior. Then only you can see the dura there. Then work out, find the space. The more transverse sigmoid junction area you expose, you can reflect the dura laterally. So you can get a better corridor. And then once you open the dura, you can take the dura there. Then the cerebellum is bulging. What will you do? This patient, top mode cuts are not there. Hydrocephalus is settled.
So it's not there because shunt is there.
Now it is okay. Shunt would have disappeared also. Man.
No, sir, it's visible.
No picture. Right? Okay, take that. Okay. Okay.
Next.
You do all image guidance and all here for vestibular surgery. Image guidance you use for
No.
actually when you operate on something which is fixed to the bone, there is no need for all this. Understand? Then nothing is going to shift. Understand? hydrocephalus is still there. Next one, next cut, next, only one cut. Okay. Okay. But what is that cut? Can you show? What is that big thing there above? I am seeing some CSF collection there. Or infarction, what is there?
Cerebral hemisphere, sir.
No.
Any more pictures are there? Told you, man. Only this much, But some CSF collection or something, I have seen, I don't know how is that. Okay. It was done elsewhere, no? Okay. So, you are opening. Cerebellum is bulging. What will you do? What will you do? CSF is, cerebellum can bulge, you have seen here, large tumor, cerebellum sometimes will bulge. So how will you make the cerebellum lax?
Sir, in the preoperative scan, the history of hydrocephalus is already.
No, that is all done, man. They have done like this only.
Sir,
Nothing prevents a patient from still having a bulge, man. So what are the various causes of a cerebellar bulge, then how will you manage?
Sir, one option is that keeping the bulb for the.
Yeah, you can, that is the last resort. Always you can keep a burr hole pre-operatively to tap the ventricle, or you can put a external ventricular drain. That's the last. Large tumors you can do that. But this patient already you have put a shunt tube. Understand? So if it is not there, you can keep a external ventriculostomy. So at the surgery, cerebellum is bulging. So initially you should check for tube and all. Whether the tube is kinked, whether they have a distended bladder, whether you are compressing the, you tape, Suddenly you strap the patient to the table, suddenly abdominal compression is there, distended bladder, airway obstruction, they can all produce bulge, understand? So check that everything is normal. Other thing is, check for air embolism, it can produce cerebellar bulge. So all this issue you can see, you make it lax by opening the lateral cerebellomedullary system, or if it is still bulging, you can tap the ventricle. You can reduce the ETC, you have to ask them to hyperventilate like that. These maneuvers you can do. Still, if it is bulging, what will you do?
Open system
That all done. Initially, with lateral cerebellomedullary system, sometimes it will be plugged with the tumor, a large tumor. So, you release the CSF, it is still cerebellum is not falling, they have hyperventilated, they have brought the SpCO2 down, you have tapped the ventricle, everything, cerebellum is bulging. So one is you should close and come some other day. Some problem is there. Second is
You can resect some part of
cerebellum. You can do that. If you have to finish surgery, resect third of cerebellum and proceed if you have to finish. Okay. And then how will you start once you have identified the tumor, how will you proceed? The surgery is, you have to take out maximum tumor without producing problem. You have all monitoring, you are monitoring all muscles, man, oculi, ovaries, everything, even endotracheal tube to monitor larynx. So everything is there. So you have opened, how will you start proceeding now? Usually facial nerve is not posterior, no? Anterior only, no? Yeah. You people have assisted restoration, no? 5 cases also you would have done, no? All of you. And a good resident would have assisted 5 to 7 cases in his, only that much you get because so many residents are there, no? Okay. So after that, no facial nerve there. Then I don't want to confuse you with the, these vestibular cyanomas are subarachnoid tumor or extraarachnoid tumors? What is that? Extraarachnoid. So I don't want to confuse you, man. Otherwise, actually now it is thought to be a subarachnoid tumor. In that oration, I will clarify that. Because initially while I taught so many people and all, I also taught them, all my residents in my days, as extra-arachnoid tumor. But it is now presumed to be subarachnoid origin inside the canal. Then they behave epiarachnoid for some time to become subarachnoid again. During my oration time, I am talking on vestibular sinus only. I will make it very clear. Understand? So you peel the double layer of arachnoid. Understand? So after that, it is only intratumoral decompression, intratumoral decompression, intratumoral. Your first stage, second stage, third stage, everything is intratumoral decompression. Because until the tumor becomes slack, you should not wander around. You suddenly think that you can take it out like a tennis ball. Like people, unskilled neurosurgeons, they remove this convexity meningioma like ball, should never be removed. Understand? There is arachnoid layer. You peel out that arachnoid layer everywhere, wherever it is. Then you decore the tumor. That layer will still, you can keep on. So ultimately, when you remove, there should be a layer of arachnoid covering the brain. Whether it's a convexity meningioma, whatever it is. You keep on decoring till the tumor becomes slack. Then out you hold the capsule, peel that arachnoid. And then once you remove that, arachnoid should be there. Understand? Otherwise, people will put a finger. You should never. If suppose somebody removes a tumor like that, that fellow still has not learned. Understand? Neurosurgery. So vestibular sinus is typically keep on doing, remove the arachnoid. But this arachnoid, that fold cannot be maintained. At some point of time, you enter into the subarachnoid space. That controversy I will tell during my dissection time. And the key message is you should keep on decoring, and start fiddling outside, start dissecting the arachnoid only after tumor becomes slack. Inside bleeding, inside the tumor, bleeding occurs, it is easy to control. You can either coagulate or put some gel form or press or something. Outside you wander, you will come into all vessels. So you should never wander outside till you have made the tumor lax. And then you start cutting the capsule. And then go inside again, decompress again, peel, cut the capsule. Like that you deliver. And in between you have to go to the canal and take out the tumor. And remove it in total. I will show videos, multiple videos. Now you are doing a very good surgery, nice surgery. Where cerebellum had become very lax. You are very happy. Suddenly cerebellum starts filling up. What will you think, Amrita? Namrata. So it is like that, when aneurysm ruptures, during dissection, what will you do?
Look at the.
You should pray to God, nothing should happen to the patient. Understand? So locate, cookate, all will come later only. Understand? Only God can help you. There is a saying by Hunt Badger and Duke Sampson. He's a very senior, very good. He was in Dallas, Southwestern University. What he has written in his book, if an aneurysm has ruptured, what he has told is, nothing has happened to the patient, don't worry. Your next unwanted move may kill the patient. That is what that means. You have to maintain total calmness. Understand? Let it bleed, nothing, the patient is not going to die. You can control. But unnecessarily you put some big thing, you make fuss there, you lose the patient. Like that, in cerebellum, you have not damaged you are operating very well. There is no bleeding, no venous problem, nothing. No arterial rupture, you have not wandered around also. It is not arterial rupture. And cerebellum is bulging. Tumor is like that, you are doing, cerebellum is bulging. And suddenly you have prayed also, it is not stopping. What to do? You did all the praying meantime. So you should check what all things, checklist, you tell anesthetist whether the tube is blocked. Understand? Whether bladder, catheter is blocked, airway obstruction, you do all these gimmicks. And they are telling, no, it must be bleeding. Anesthetists will tell they will advise you it is bleeding, man. But we tell, no, it is not bleeding. And then, what will strike your mind then? Cerebellum was very lax. Very, very lax cerebellum, it can suck air inside. And it will be a pneumocephalus up. Or it's some supratentorially hanging thing, very lax brain. Some veins can rupture. So it is pressure building up supratentorially, which is coming down. Understand? You should think of that. If it is bulging like that, you bring the head and up, do everything. After that, if you cannot proceed, and there is nothing there, you have to take out, you cannot proceed because of bulging cerebellum. You have to have, you close the thing, suck out some cerebellum, make all day, take patient for a scan and see. And you can always come later. You cannot work with a bulging cerebellum. Understand? It can bulge sometimes in between. But you wait for some time, give diuretics, hyperventilation, it should settle. But you should always exclude a pneumocephalus subdural collection if it is a very, very lax cerebellum, becoming tensed up. Understand? So you take it out, man, take it out. You do craniotomy only, you keep the bone back, Craniotomy only you are doing, Still many people still they tell, no, craniotomy is dangerous because initially itself the game is lost once your resident or somebody opens the sigmoid sinus. That is all. You have seen all sigmoid sinus getting open. You have not seen here. Right? That means you people are not exposing properly. Because sigmoid sinus, lateral edge of sigmoid sinus, medial edge of sigmoid sinus you should expose all the cases because your craniotomy or craniectomy should be right up to the sigmoid sinus. Understand? Otherwise, you cannot expose. So many a time they expose the sigmoid sinus, then you control that with all, and then after that you close everything. Then you are opening cerebellum will bulge. You have to control that. The game is like that only. Vestibular sinema game. Before I close, a simple thing I will tell because I have to take other thing. Which are the things hyper dense on? Which are the things which are hyper dense on a plain CT? Calcium. Highly proteinaceous thing. Blood. Then ferritin, iron, calcium, highly proteinaceous thing. They are all hyperdense tumors. There are some hyperdense without contrast also. Highly cellular tumors. They are hyperdense on CT. Plain CT itself you show it is hyperdense. Not like a contrast, but it is hyperdense. So one is medulloblastoma, a posterior fossa tumor. If it is hyperdense, relatively hyperdense on CT, on plain CT it is medulloblastoma. Like a highly cellular tumor can be hyperdense on CT. So highly cellular, proteinaceous, calcium, these things can be hyperdense on CT. More importantly, what I wanted to ask is, which are the things which are hyperindense on T2 weighted, hyperindense on T1 weighted images?
Fat, sir.
Fat, agreed. Then the flavoid fat, again high proteinaceous things. Understand? The T2 weighted images, everything should be hyper, normal thing. If it is hypo, flavoid fat they have told. Other is high proteinaceous things. That is like, you have a supracellular cyst, craniopharyngioma. You have Rathke's cleft cyst and other things. If the protein is between up to 9 grams, it is hypo on T1, hyper on T2. If it is 9 to some 15, 17, it is hyper. If it is above 17 grams, T2 it will become hypo. So highly proteinaceous thing will become T2 hypo. T2 hypo people will ask. People told. Then you have highly proteinaceous fat. Then things with low proton density. Things with low proton density are highly cellular tumors like medulloblastoma, lymphoma. They are hypointense on T2 weighted images. Understand? Or fibrotic lesions. Anything which is fibrous, a tumor which is fibrotic meningioma, it will appear hypo on T2. A tumor which is highly cellular, which will appear hypo on T2. So you give a contrast. If it is enhancing, you know it is highly cellular tumor. Then paramagnetic substances, ferritin, hemosiderin, deoxygenated hemoglobin, intracellular methemoglobin, they are all hypo on T2. So everybody will ask which are the things which are hypo on T2. It is not we want hyper on T2, and things which are hyper on T1 also. That is all. That also you should know. Hyper on T1 and hypo on T2. Understand? That is offshoot of this only. So post-op management, you people know how you take out the extubate same day before taking a scan, or what you do, or in the table.
Intubate overnight, and early morning we'll take a CT scan.
Then if you are intubating, overnighting, always better to get a scan, and then don't do without that. Understand? Small tumors you can extubate, but large tumors, I never used to extubate. I used to get a scan. Only thing relatives all are worried by taking a scan. It is for us satisfaction. If we are going to ventilate, then take a scan. And we are very sure. In Chitra they have intra ICU CT scan. So now they can do also left and right. It is, as and when patient requires you should do, not that evening, morning like that. And then morning it is okay, you can extubate, no? Okay. Okay. Now what we do is, with other case, 1 hour. Who is presenting? Okay. Don't worry. The post-op scan is there, this patient. When, okay, get there. Get just up picture, there was some tears of pouch I had seen. So we are going to the second case, which will I take very easily. The other one is over, 3 hours into. That is over. Now what I will do, they have another case. I will take it the reverse way. And I will tell you some juggleries which you should know for examination. This I will quickly and tell how to localize something in the spinal cord, various areas, how to localize. Understand? Which is more important for you. What is that? I didn't hear.
Sir, he is asking the difference between extreme lateral, far lateral and extended far lateral.
Extended far lateral is, you are removing the condylar, drilling in the condylar triangle. The other is apoccipital triangle only you are working. Understand? In extreme lateral and far lateral you are working in the, what you are interested only is in vertebral artery. In far lateral, if you are not transposing you are exposing the vertebral artery over C1 arch in both the extreme and far lateral. In extreme lateral, you are taking the vertebral artery out of the canal. C1 transfers foramen and then working in front of that. The other one you are still working behind. In extended far lateral, it is not. It is actually you are drilling the. You are going here. You are working in the suboccipital triangle. There you are working in the condylar triangle. That is between the superior oblique, rectus capitis lateralis, and our bone. Okay. So 77 years. Okay. So another thing, when you talk loudly, the examiners will get scared little bit. They will keep quiet. If you tell means they will pounce on you. So always talk loudly means they know that you are extremely confident. Understand? So loudness gives confidence. Okay. Okay.
Mr. Gottappa Dottamani, 77-year-old man, was a farmer by occupation with no formal education from Kolkata and has given his own history in Kannada, which is reliable. He presents with the chief complaints of neck pain and restriction of neck movements, tingling and numbness of all four limbs, and difficulty walking for the past 4 weeks.
4 weeks.
Yes.
Why your patients are coming very 4 weeks and 1 month only? Okay. Yeah.
So patient had a history of sudden lightheadedness and blacking out while passing urine in the bathroom early morning 4 weeks ago. Following this event, he woke up on his own and it lasted less than 3 to 4 minutes. And he was found on the floor by his son when the
So
patient
he fell down. Okay.
position with the head, the top of the head tilted towards the right side. Gradually, in 4 to 5 days from the event, pain decreased to a dull ache only in the upper neck and occipital region of moderate intensity, which worsened with neck movements and was relieved with painkillers. He also noticed restriction of neck movement while turning the head from side to side, more towards the right. Family noticed that his chin was tilted towards the left and his head was tilted towards the right. He was able to shake his head like saying no, but had pain after the initial movement. He noticed tingling and numbness of all 4 limbs and torso post-event. It was sudden in onset, progressive, initially mild and became severe within a week of the event. It started in the soles and progressed upwards to involve bilateral lower limbs, more on the right than the left, and then it involved the torso and upper limbs. It was associated with decreased sensation of clothing over the whole body since the last 2 weeks. He noticed that he could feel his shirt and lungi but less than normal. Of this, the numbness and reduced sensation was worse over the lower limbs than the upper limbs. He also had decreased sensation of his collar over the neck. He also perceived cold water less than normal, neck downwards, while being given a bath. He had normal sensation over his face and could feel a comb on his scalp and pillow behind his head normally. Initially after the Initially after the event, patient was on bed rest for the first 2 to 3 days, during which time he was able to lift all 4 limbs against gravity and turn on the bed. After this, he started walking with the support of one person. He noticed difficulty with the feeling of buckling of knees and hips. He also noticed that he could not grip his chappals and he was aware when the footwear would slip off but was unable to guide his foot back into it. Following this, he developed difficulty in tearing chapatis and buttoning and unbuttoning of his shirt. When he would place his arm around his son while walking, he experienced progressive difficulty in gripping his son's shoulder. Gradually, he also began having difficulty in lifting a mug of water while bathing. He developed tightness of both lower limbs in about 2 weeks from the event, initially noticed in the calf and then bilateral lower limbs, especially when he would attempt to sit cross-legged. Initially, patient required minimal support, but since the last 2 weeks, he puts his full body weight on the son, and in the last week, he occasionally needs the support of 2 people to walk. Since the last week, he is unable to get up from lying down position even with the support of both hands and needs to be lifted up. He also now has difficulty in raising his arms up to wear a shirt. No history of fever, past TB infection, throat infection, neck mass or any other known malignancies. No history of multiple joint pains, joint stiffness, morning pain, multiple previous fractures. No history of cough, headache, no shock-like sensation over the neck when on neck flexion, no burning sensations, sharp pain in any limb, glove and stocking distribution of or tingling sensation, no band-like sensation over the chest or abdomen, no skin changes, non-healing wounds or ulcers over the feet, no history of diabetes, no history of drooping of eyelids, decreased sweating over the face, no history of imbalance while swaying or swaying while washing face, tremors, smearing of food around the mouth, no history of bowel or bladder disturbances or erectile dysfunction. No change in smell, vision, double vision, eyelid drooping, No history of difficulty chewing food, numbness or reduced sensation over the face, facial pain, redness of eyes. No history of deviation of face, inability to close eyes, change in taste, hearing or vertigo. No difficulty in swallowing liquids or solids, nasal twang of voice, nasal regurgitation or any cough after food. No deviation of tongue or difficulty in making a food bolus in the mouth. No history of drooping of shoulders or difficulty in shrugging. Past history, he is a recently diagnosed hypertensive on medication and no significant personal or family history was given. So summarizing, it's a 77-year-old man with a history of fall in the washroom, following which he developed mechanical neck and suboccipital pain, neck deformity with restriction of neck movements, ascending paresthesias of all four limbs, spastic quadriparesis without involvement of lower cranial nerves. So substrates involved are corticospinal tracts and spinothalamic tracts, and I am considering an extradural compressive.
There is no sensory symptoms in go back. You have told no difficulty. Somewhere you told there is no go back. No burning sensation, sharp pain, any limb, low and stalking distribution, tingling, nothing is there. No bad sensation. That you have told.
No,
now you are telling some ascending something.
Sir, ascending paresthesias are there. I only mentioned there is no glove and stocking pattern of that distribution did not come in that pattern. He had tingling and numbness which started in the soles and rapidly progressed upwards to.
Okay. Okay, I go.
Please come back 2-3 slides. Come back. Yes. Next slide. Next. Yeah. This one. Sir, the negative history was to show the pattern, that there was no pattern suggestive of peripheral neuropathy, but he gave a classical ascending
What is
paresthesia.
the pattern of peripheral neuropathy?
Like for some metabolic peripheral neuropathies can.
Peripheral neuropathy, what is the sensory loss you expect to have? Love and stalking.
No, so metabolic causes of peripheral neuropathy can be, that's what I meant.
No, actually, anything, love and stalking, can come for peripheral neuropathy. It can also come for our spondylotic or whatever. Both can produce love and stalking. You understand? The other one is because of length dependent involvement, the peripheral neuropathy. Understand? The distal part will get affected. What is the difference between the one from compressive? Both hand and glove stalking can come for both, for cervical spondylosis also. So if you don't know, you will think that this fellow is having peripheral neuropathy. It is described for cervical spondylosis also. They will. So what is the difference, between that, in peripheral neuropathy, it is always graded sensory loss. Understand? Distal will be more affected as you come up. If they have up to stalking area here, distally will be maximum affected, then it will be less. And also it is like that. In compressive, it is affected totally. Whatever is affected is will go. So that gradation is not there for compression. So the thing is, they can also have a central periphery loss. The point which you have to tell is, in compression, in periphery, in the peripheral sensory, the neuropathy will never extend above the knee without involvement of the hand. If it is in compressive, if suppose somebody has got a peripheral neuropathy like sensory loss, findings like that will come above the knee without involvement of the hand, it is compressive. Understand? The point I am making is, one is graded loss for peripheral neuropathy. And peripheral neuropathy, by the time it reaches the knee, always hand will get involved. Understand? That is a classical finding. Graded and hand will get involved by the time it reaches knee. The other one, not graded, and it can come above without involving the upper. Understand? Okay. Some gimmicks I will teach you. These things every Okay, now present disability.
Present disability, sir, he is walking with the support of 2 people.
In spite of all this,
Yes, sir. He's practically
so
incapable
also
to.
anatomically, a corticospinal tract, why is so patient can walk with eyes closed and all.
Sir, he doesn't have added feeling of imbalance when he's washing his face and closing the eyes. But as for walking in the dark with eyes closed, that was not attempted by him on because he was having so much difficulty.
Washing the face and all it becomes more unsteady. The walking, so just washing the face with water and all, suddenly you pour water. You are blind at that time, no? That time does he become unsteady?
No, sir, he does not. He does not become
Because why I am telling is, you are
Dorsal.
telling corticospinal tract and spinothalamic tracts are getting affected because of extradural compression. Understand?
Right.
So why extradural compression going with, I want to tell is, corticospinal tract, the larger myelinated fibers are most vulnerable for compression.
Mechanical compression.
Compression, tiny compression. So the largest myelinated fibers are pyramidal tract, equally larger myelinated are posterior column. So if posterior if pyramidal tract is affected due to a compression, it is almost sure that they will also affect the posterior column. That is the hallmark of compression. And they go hand in glove. Spinothalamic need not get affected in compression. So that is what that history, you should have taken in detail whether they have any difficulty in. If you are thinking it is compression, definitely posterior column to involve spinothalamic, definitely posterior column would have gone. Understand? Only thing you are telling that cotton wool, those things are not there.
Not there, sir, and also he
at
has
history
no
level.
ataxia.
We are still at history level, not clinical examination
Yes,
level. So you are telling vertically, why did you tell it is CV junction?
So because of the deformity. Okay,
Okay, because of the deformity, you think something is.
At the
I am
same-
telling patient has got some C2-3 dislocation.
it will with the C2-3 dislocation and
And then
perching
deformity is because of that.
could.
How will you counter that? You are telling CV junction, I am telling not CV junction, it is below.
Sir,
So
he
you
also has
could tell
suboccipital.
anatomically or
Uh-huh.
vertically high cervical region. Like that, at this point of time,
Okay,
high cervical, because the patient cannot turn. That is
Yes,
why
sir.
you are telling.
Yes, sir.
Okay?
Because of rotational restriction, I am considering.
Anything, any cervical, your cervical spondylosis also with radical, they will not be able to turn with severe pain. So if there is a mechanical, painful means, it is radical. If it is mechanical, I agree. Without pain, if they cannot turn, it could be very high up. Understand? So
Yes, sir.
fracture dislocation, atlantoaxial dislocation, rotation, everything you are seeing. Your eye must be great. You are seeing everything,
Just-
dislocation, atlantic, rotation, lens fracture. That only you have not told. Where the lens is fractured.
I am considering.
Everything you have written. You are telling that atlantic dislocation, Lewis grade 4 also. That also without examining you have told. Lewis grade 4.
Yes, sir, sorry, sir. No, but because he is not able to do gainful employment and he is unable to
Somebody can
do
walk and
household
all.
chores.
It is Lewis grade 4.
So he is not able to walk without any.
That's what I told. What is the present disability?
Yes, sir. So he is with 2 people support. He is able to.
Forget about that. You come, we'll analyze. So
Okay.
suppose somebody has got this is basic. And what we will do is, suppose somebody has got such a history. The anatomical substrates, you could tell whether pyramidal is affected, posterior column is affected, spinothalamic is affected. Of all the 3, spinothalamic tract is the least vulnerable for compression. They are more vulnerable for ischemic injury. Nothing prevents from the fellow from having both compressive and ischemic injury. Understand? But they are the least vulnerable for compression. So always you should have some definitely urgency of situation. That is not there.
No, sir.
Even 70, I am 70, I am getting urgency every now and then without having the spinal cord problem. Everybody will have that. 77-year-old fellow, they will have some urgency of situation, one from brain going away, other thing, that will be there definitely. It will not go hand in glove. 77, you should not ask for erection, but at least erection is important because you have one is a reflex erection from S2, 3, 4. Other is a psychogenic erection, which is from sympathetic involvement. Understand? So some people can have a reflex erection without having a psychogenic erection. If there is the lower part is normal, S2, 3, 4, they can still have reflex erection. Psychogenic erection can be impaired. So that history you should ask not for a 77, but 77s are also very active males sometimes. Understand? So that history you have told. Bladder I am not very impressive with your history. Yeah.
Patient would previously have history of straining while passing urine, but other than that, he has no other urinary problems. And when he had the fall also, he was straining.
If the patient, in spite of having so much problem, still you are telling no urgency of micturition. They will have something, some upper motor neuron bladder should come. I am not talking of a reflex bladder. They will have some upper motor neuron symptoms should have come to the bladder. Reflex, that not only total reflex emptying, some urgency will come. Okay. Next, so when you have that, you have told substrate everything, how will you find the correct level? You have told anatomically, you have to tell a level. Your level is the topmost level. You can have a sensory level, you can have a reflex level, you can have a motor level, you can have an autonomic level. So then if you have 4 different levels, it is your level. Highest one. So sensory may be far low down because of lamination. It may be very low. Let me tell you, Amrita, anybody who has got a C2, 3 also will have difficulty in lifting. Understand? Say your level, I am telling it as C2, 3. So how will you tell? It is not foramen myogram. So how will you tell? After clinical examination will come. At least now she is telling high cervical cord. Point which I have to make is, all the 4 may not correlate. Motor, reflex, sensory and autonomic, whichever is highest is correct. So autonomic level, after examination only probably you will be able to find out. I will tell how to find out that whichever highest is highest. And she is telling anatomical substrates, all these are involved, and horizontally she found out that plane of the lesion is extradural. Because of pain, limitation of neck movement, she is putting more into a bony problem. And level she has put very high up because she is telling collar sensation only can feel well. Okay, so you are telling so many other things which is not required. People you take some dal. What dal is that? What is that? Because they all can produce spastic weakness. So history of exanthematous fever, ARV vaccination, exposure to toxins, then this dal, these things should, as a negative history, other than trauma, other things you should tell, so that people will know that, okay, you are ruling out all these things. Understand? They can have, say, demyelinating things can have some visual problem. Those things should all can have, not necessarily. So, whether it is waxing, waning, or saltatory, or worsening, like that history should come. Okay. How will you measure the head, neck, head, this ratio?
So head we will I need the patient to stand in
There are various ways of checking. Yesterday I had to take class for Minman's people. So while I was in the flight only I correctly learned. I just thought these people head to neck height 1:13. What is this 1 and what is this 13? So many ways of measuring. One way you should. People were telling external occipital protuberance to C7, which I found is not there in many of the measurements. There are some other ways of measuring. Measuring from here, there, like that. So many measurements are there. Check one. Okay, hairline. What is the normal hairline? Okay, some people tell up to shoulder level also. I don't know. Okay, keep on moving. Yeah, head tilted to right. Okay. Suppose the head is tilted to right, chin there means I will tell the patient has got the chin side trochlear involvement. Okay, go. Okay. Go. This I have seen because you have to discuss. I will teach you some gimmicks for examination.
Yes.
That is more important.
Higher mental functions are normal, sir. To summarize cranial nerve examination, there was no possibility.
No, okay. So, hold on. Very important. If we have to test one cranial nerve for a high cervical lesion, not CV junction, which cranial nerve will you test? Why 50 you have to tell? Fifth, 1, 2, 3, 4, 5. You are in which year? First year. I should not ask the question which route time we used to ask. After that, you people should not run away. You should stay there only. Which Amrita, which nerve you check? One cranial nerve. Say if high cervical lesions will not affect any cranial nerve except fifth nerve, because descending tract of fifth can come up to C4 level. Understand? So you should, which level where you will check for sensory thing, because it is ophthalmic division. Ophthalmic division which comes low down. Other things all will not descend down. Other cranial nerves will not get affected. If it is a CV junction, so many cranial nerves can get affected, like spinal accessory, fifth nerve, 12th nerve. Understand? If it is in the CV junction, understand? But otherwise it is fifth only. Understand? Like that. Trapezius, everything is normal, restriction. What you are telling?
Yes.
Up to 10, 11, everything is okay. So after that?
The trapezius is normal, sir. The sternocleidomastoid, because of the restriction of
You cannot touch properly.
Yes.
You wrote correctly. Other thing always you should look for is, this patient obviously has a post-traumatic problem. Otherwise, anybody, high cervical CV junction, she has written no downbeat nystagmus. I will ask you 10 findings for CV junction and some findings pertaining to high cervical region, which is not CV junction. Above C5, but high cervical. Understand? Other one is CV junction. Other thing is medullary in the spinal, in the brainstem. So these things you remind me. Understand? Okay. Next one, because we have to rush. That is where.
Motor system examination. So shoulder examination grossly on.
Instead of telling, if there is a pyramidal weakness, instead of telling 4 plus 4 minus 3 plus, it has no significance for us. If it is a pyramidal weakness, it is upper limb, it will be extensors which will be more involved than the flexors. While in the lower limb, it is flexors which are more involved than the extensor, because anti-gravity muscles get little sparing. So upper limb anti-gravity muscles are biceps, adductors, wrist flexion. They are relatively okay compared to abduction, extension, like that. So in the upper limb it is the extensor. So if you tell in the upper limb there is a differential weakness between extensors and flexors in the upper limb, it is extensors are more involved.
Yes.
then we will open the eye. So everything you write 3, 4 like that, it has no value. And lower limb is other way around, because there flexors are more involved. That is our hip flexion, knee flexion, plantar dorsiflexion. They are more involved. Anti-gravity muscles they are less involved, like our quadriceps, plantar flexors. They are less involved, like hip extensors. So there also you should tell flexors are more involved than hip flexion is more involved than hip extension. Knee flexion is more involved than knee extension, like that. And then we know you are talking of pyramidal. Understand? Otherwise it will not give us any clue. Understand? Understand?
Yes,
okay.
sir.
Next, leave. I will. Everything shoulder, elbow, left, right, all same only. Everything, this extension, flexion, grip has no value. Upper limb flex. Oh, you have written. Oh, great actually. Upper limb flexors less involved. Left less involved. Upper limb extensor. You have written that. Oh, you have written that. Sorry. Okay, because the key thing is anti-gravity muscles are less involved. Anti-gravity muscles in the upper limb are
Strong.
okay. How will you test for bicep strength, Amrita?
Bicep strength, we have
No, you can examine on him. He has got weakness. You just, or if you don't want to touch him on here, you can tell. I want you to demonstrate. How will you examine for biceps weakness for her? Come here. You can sit down also. Okay. Tell.
So it will be done in
So you ask her to contract.
next year.
That is precisely you should not touch.
And this
Understand?
movement-
That is what you flexor muscle. Totally. Now you flexor muscle and then test for bicep. You ask her to flex. Now ask her to flex.
Okay.
Understand? Now ask her to flex. That is how you should test. Not like it should be. It should be the maximum or at least 70%. It should have flexed or contracted thing only. You should check. You should not ask her like you started like that. Now flex. It is not like that. Now you should check. Now ask her to flex. Understand? Every muscle is checked like that. Understand? Every muscle should be checked after it has partly or almost 75% contracted. Then you check. Understand? Otherwise you cannot check the power. Right? Okay, next.
examination and hypertension, saturated and body. There was no graded hyperesthesia, but then there was lower limb.
What about 2-point discrimination all affected?
Oh, sorry, intact, sir. Intact, I wanted
But
to say.
still I will not believe when JPS and vibration are intact. This much spasticity. Bilateral, triceps, supinator, everything 3+. Hoffman's, spectralis, all.
It's exaggerated, but
What is
that's
HCH?
grade 3 hypertonia is there, sir.
SCH is what?
So scapulohumeral reflex.
Very good one. How did you get that actually? Scapulohumeral reflex, you test always here, right?
Yes, sir.
What is otherwise called?
Biceps is exaggerated.
Shimosu's reflex, very good man. So you have written SCH only.
Sorry, sir.
Shimosu's reflex, that is what plus NT.
Yes, sir. It is present, sir.
Okay, NT is present NT. Okay. So why you have to mix Hoffman there? What is the significance of Hoffman? Significance of pectoralis? Significance of Shimosu?
Hoffman is a pathological reflex which is present at the lesion, which shows lesion above C7 level. Pectoralis is.
Look, I cannot hold your ear because I will be arrested. Because finger flexion is C8. So any pyramidal lesion above C8 is not above C7. We should be very clear. Finger flexion is So any pyramidal lesion above C8, it can be C7, not lesion above C7. It will produce positive Hoffman. Understand? And then what is the significance of because you are what is the significance of pectoralis and shimus scapulohumeral reflex?
So just to establish the vertical level.
How will it establish? Then you should have told me about biceps also. You should have, why you have not written biceps there? That you have not written. So why you have written, suddenly you have written C8 you are telling. Then what is the localization of pectoralis?
So biceps, the idea.
No, agree. Why you have written, what is the localization of pectoralis and shimusu?
C5-6 and C3-4.
Which is C5-6? The thing is, a point is, I have to tell is, if suppose somebody has got a compressive myelopathy at C5 level, they will not have pectoralis and CH positive. Mechanism is very difficult because, pectoralis, the root value is 6 only. But still, for a compressive lesion at C5, it will not come. For a compressive lesion above at C2, 3, 4 level only you get, above 2, 3 level only you get a pectoralis reflex. And this also, you hit the spine of scapula, you get this shimusu reflex. It is also for high cervical. The thing is, which muscle, if it is normal, he has no problem at C4. You got my question? One of the muscle you check, if it is normal, there is no problem at C4. What is it? Dorsal scapular nerve is what? Some good name. No, rhomboid is C5. Boss. Rhomboid is C5. Rhomboid is called what you told, dorsal? Okay, but that is C5. Rhomboid is very clear, C5. It's a deltoid C5, supraspinator C5, subscapular C5, infraspinator C5. When it comes to bicep, 5, 6 component is coming. This is 6. Supination, pronation, brachioradialis, then wrist. This I will tell you, wrist flexion and extension, contrary to everything, all extensors are C7. All flexors are wrist, there is a confusion which I will tell you. This is 8, this is 7. Wrist I will tell you. Wrist always there is a confusion. Supination, pronation is 6. Supination, pronation both are 6. 7. 5, 6 component also is there, biceps, brachialis. Understand? And brachioradialis is supplied by radial, but it is not supplied by C7 root. Understand? Which also I will tell you. But most important is you should know all these levels. Wrist also I will tell you. Wrist, the major wrist extensor, is flexor and extensor carpi radialis. Extensor carpi radialis is there, flexor carpi radialis is there. Understand? So normally everybody will tell that extensor carpi radialis is supplied by C7. Because 7 are supposed to be the extensor. It is not correct. And this also everybody will tell it is C6. But it is not correct. It is actually, flexor carpi radialis. Flexor carpi radialis is supplied by C7 through median nerve. Understand? Extensor carpi radialis is supplied by C6 through radial nerve. You have understand this jugglery. So when it comes to wrist, the major wrist extensor or flexors are extensor carpi radialis and flexor carpi radialis. Flexor carpi radialis is supplied by C7 through median. Extensor carpi radialis is supplied by C6 through, because other flexor carpi, ulnaris, other things are very small muscles. Understand? So that is a major catch. That is why if suppose somebody has got a C7 involvement, what muscles will you check? C7, you have to distinguish from a radial nerve. C7 from radial. Because, C7 will produce extensor weakness. Ready will produce triceps weakness. C7 will produce triceps weakness. So you have to look at some muscles which are supplied by C7 but not by radial nerve. Understand? And also you have to look at some muscles supplied by radial nerve, not supplied by C7. You understand? So which are the muscles which are supplied by C7, not by radial nerve? The most important muscle is latissimus dorsi. Latissimus dorsi. Understand? And other C7 muscle which is supplied by not by radial nerve but by median nerve is flexor carpi. That important muscle. That is the muscle they do EMG studies to see whether it is a radial nerve or C7. EMG they do for flexor carpi radialis. It is not the other muscle. That is a C7 muscle, flexor carpi radialis, but still a flexor. The other thing when you look for other is brachioradialis. Brachioradialis is a muscle supplied by radial nerve, but not supplied by C7. Understand? So this jugularly you should know, very important. Right? So what we are telling is spectralis and SCH are, SCH is a new terminology. I always call Shimusu reflex only. Okay. It will take you up. Which is other thing which will take you up. So C for levator scapula. If levator scapula is normal, you know patients up to C4 is okay. Understand? Other thing, diaphragm. Diaphragm main, it is C3, 4, 5, main thing comes from C4. Understand? If diaphragm is intact means your C4 is intact. Understand? Say suppose I have one side diaphragm affected. Say if I ask the patient to lie on that side down, they will have respiratory distress. Understand? So C4 is the main for diaphragm. Levator scapula, you check how it is tested. That is, if it is normal, C4 is normal. So higher levels you do this pectoralis reflex and SCH. Normally a C5 myelopathy will not produce exaggerated pectoralis reflex and SCH reflex. Other important thing I told you is, do this thing. Everything is exaggerated. So everybody will, they will think that that also will get exaggerated. You understand? That is the common thinking. So everything is exaggerated. Next thing they will judge and immediately you will tell it is also exaggerated. So if it is exaggerated, you are not dealing with that cervical spine problem. You are dealing with a high brainstem problem. Understand? So very important to test. Only cranial nerve which can get affected is fifth cranial nerve, ophthalmic division. Other things can, so these things can take you to a high cervical level. Rest of the things you know. Understand? You should know how to differentiate a root from a peripheral nerve. Understand? And plantar extensor. So autonomic level is, you have not checked. Can you tell the sensory 2-point discrimination temperature C3? So what is C3?
No, sir.
Pain and temperature.
Yes, sir.
What is your C3, Amrita? What is your C3? It may not be my C3. So what is your C3 is this angle of the mandible. Understand? That is why if anybody is telling in this trigeminal thing and all, angle of the mandible is the classical area for C3. Understand? Collar is there, no? Collar is C4. Here C2. Understand? Back is C2. Other things you know. Understand? Angle of the mandible C3. Okay. So everything is diminished below C3, left more than right. Next side. The other one, autonomic level, you scratch from below. For somebody, you look for V. So it will be absent. So some place you will start getting that. That is autonomic level. Understand? It is little painful for the patient. They will not appreciate. When they start getting that thing, only they appreciate. It will be very good sterile thing. You clean everything with spirit and keep on doing that. So if autonomic system is working from that level, vibration always check on the spinous process. Understand? Okay. How will you check for corneal reflex? That I forgot. Corneal reflex, everybody will ask. What is the afferent for corneal?
Sensory ophthalmic,
So, say V1, V2, V3, which is affected?
in the for the afternoon.
Afferent.
Yes.
So, that is what it is. 270 of the cornea is by V1. Below that 5 o'clock to 7 o'clock is by V2. Understand? Just know that. Not totally by. You can tell V1, but it's not totally correct. Understand? Lower 5 to 7 quadrant, 270 by V1. Understand? That I should have told you on that thing. Let me one more question. Suppose I have corneal reflex. What is afferent and efferent for cornea? Corneal reflex.
Different.
Afferent and efferent both are trigeminal.
Efferent, right? Please your ear.
Sorry. Yes. For corneal reflexes, sorry, I was stuck on George. I'm sorry. Corneal reflex efferent is facial nerve, sir.
Okay. Suppose I have my efferent is affected on this side. So if I do cornea, what will happen? My efferent to this side, I have a seventh nerve palsy. I have a seventh nerve palsy here. You are checking my corneal reflex. What will happen? The other side you can see that. Understand? You agree? Suppose my afferent goes means both will go. Understand? Now I will ask you a bigger question. Both facial nerve palsy is there. Both the side patient has got facial palsy. Understand? So how will you tell me whether patient has got afferent intact or not? You got my question? You have not got my question. I will bring this
Both sides
up.
facial transcription is there, eyeball is not doing, but when we attempt to do it.
Very good, doctor. I never expected that answer from you. It's called Bell's phenomenon. Understand? You can look for Bell's phenomenon. Understand? Okay. Leave it like that. You are very good neurology. Okay. Next thing, keep on going. What are the 10 findings for CV junction? 10. Anybody can tell. Come, I look at this side.
Low set.
So those 4 things are there. I will tell short neck, low hairline, C2 small muscle waiting, C2 hypothesia. These 4 you keep there. 6 more findings.
Mirror hand.
Mirror movements. If suppose somebody has mirror movements, it is suggestive of, that means I drop this, I drop something from here, this glass also will fall. And then, what is that? And that can come for eye cervical. I am talking now CV junction.
Cruciate paralysis.
What is that? Cruciate paralysis. Very good. Cruciate paralysis. That you have ipsilateral upper limb, contralateral lower limb, whatever cruciate. Understand? That is suggestive of a CV junction. Then
Downbeat nystagmus.
very good. Downbeat nystagmus. Then
Limit.
that can come for cervical also. Anything, Amrita? So other is small muscle wasting. Understand? Say you have a higher up thing, your hand muscles can get wasted. Understand? Small muscle wasting on the hand. Understand? You have seen, no? Foramen magra. Other, there is, upper limb posterior column affected, lower limb posterior column intact. That is classical for CV junction because, the fibers from nucleus cuneatus, they go as internal arcuate fibers. They get involved in CV junction with sparing the lower limb posterior column. Understand? So if they have something like that, you know it is a CV junction problem. So then let me recollect. There are also some 10 findings, 12 findings are there. We have not reached anywhere, no? So 4 useless findings initially we told. Then after that we told cruciate paralysis, mirror movements, downbeat nystagmus, wasting, posterior column. So we have reached 10. Okay, by the time lunchtime I will tell. Understand? So 10 findings you should memorize. These things you should look for. The other things can come for everything. Other thing, something very typical for high cervical lesions, which we told. What is myelopathic hand? You must be knowing, no? Myelopathic hand is classical for high cervical. Cervical spondylotic myelopathy. Myelopathic hand is, you ask the patient to, like this only. He pronate the hand, ask them to hold straight. After some time, these lateral two things will abduct and hand will flex. This is described by Japanese people, which is typical for cervical spondylosis. It's called myelopathic hand. You ask the patient to pronate and keep like that. You keep for some time. After some time, these lateral two fingers will start abducting and also hands will flex. Myelopathic hand. It is characteristic for high cervical. Understand? High cervical. It won't come for other things. Myelopathic hand. One more thing is there. What you call this? That fine thing will go for what hand it is? Dysesthetic hand. I forgot. Some term is there. What do you call? A piano thing only. But the hand you call some hand is there. That also will get affected. No, what is that?
Pseudoarthrosis.
Correct. Pseudoarthrosis, like that. That hand will come. Typical for cervical spondylotic. These are typical because cervical spondylotic is the one, or AAD is the one you can get for examination. So you should always test. There is no myelo. If you see, you will see that myelopathic hand. You can. What is that?
Polymyomatosis, which.
Yeah, that also piano like that. That thing can come. Okay. That we told restriction. So CV junction, high cervical. Then what about brainstem signs? Can you tell with this classical 10 brainstem signs?
IN.
Good. IN. What is IN? What is internuclear? Which nucleus to which nucleus?
Third. Sixth nerve nucleus to third nerve nucleus.
Internuclear, no? Sixth nerve nucleus to?
Third nerve nucleus.
Okay. My professor always used to tell your answer is correct, but to some other question. Understand? He is correct in a way. There is PPRF, from PPRF it goes to sixth nerve nucleus, it goes to opposite third nerve. Now people are telling that sixth nerve nucleus itself has got a lateral zone. From there only it goes to the opposite side, third nerve. So it's called internuclear, or between PPRF to opposite medial rectus nucleus. So where it is getting affected? It is getting affected on the MLF. MLF is after it has crossed from PPRF or whatever sixth you are telling, it has crossed to the opposite side, then it ascends up. So when it is getting affected, they will have internuclear. So what will happen is they will have restriction of that side adducting movement, and abducting I may show nystagmus. That is called internuclear. It is called either you call because adduction problem is there. Understand? And abducting I will show nystagmus. So it is called high or low. Anterior internuclear. This is called anterior internuclear ophthalmoplegia. Anterior internuclear ophthalmoplegia could be anterior when the lesion is from the sixth nerve or whatever nucleus, PPRF to the opposite, you call anterior internuclear. Posterior you call from the sixth nerve, this PPRF to sixth nerve nucleus. From PPRF to sixth nerve nucleus, if there is something you call posterior internuclear. PPRF and all PPRF is there is a nuclear center in the pons. So from there, a connection to the same side sixth. If there is a connection problem there, you call posterior internuclear. If there is a connection from there to the opposite third nerve, you call medial rectus, you call
anterior. Anterior could be low anterior or high anterior. How will you find out? Both will produce internuclear, anterior internuclear. In high anterior internuclear, convergence will also go. Convergence will, the other one, low anterior internuclear ophthalmoplegia. That means already you are telling adduction is affected. Understand? But if you ask them to do, look at a point, they will be able to do that. I don't know whether you got what I am telling. Normally they will not be able to adduct. Understand? But if you ask them to look at your finger close, that convergence time they will be able to adduct. That is called low anterior internuclear. High anterior means convergence also won't be there. Okay. Okay. So one is internuclear ophthalmoplegia. Then what else?
Long tract elements.
What is that?
Long tract elements. Long tract signs.
Long tract signs you get for CP angle tumor also. Long tract. How can you put it in the brainstem? Anything extraaxial can produce long tract. It is crossed finding. Say if you have one side cranial nerve gone with opposite side pyramidal, you can tell crossed hemiplegia. Crossed hemiplegia. Okay, then cranial basal system, multiple cranial nerves can come, no? Brainstem, Horner syndrome. So, trigeminal is a very big thing. So many things can occur with trigeminal. Understand? So, the trigeminal, you know that onion peeling, you know that onion peeling loss. That is characteristic of brainstem involvement. So, you can have, say, trigeminal, you have there are 4 nuclei for the trigeminal nerve. 4 nuclei. Understand? One is the chief sensory nuclei for our touch and all. Then below that you have the descending tract. From the descending tract it goes to the descending nucleus. Then you have a motor nucleus, you have a mesencephalic nucleus. You forget about motor nucleus and mesencephalic nucleus. Chief sensory nucleus is only for touch. From the chief sensory nucleus, the fibers go to both sides, ipsilateral and contralateral up to thalamus. While the descending tract, that descending tract only we told that ophthalmic can come to C4, 5. The other one all up only. From there it goes to their nucleus, descending nucleus, then they cross across. That is called the kindothalamic tract. And they ascend up. Understand? So if the brainstem is getting involved, you can have so many involvement. Say you can have spared touch sensation. Suppose somebody has got trigeminal with a spared touch. Means the chief sensory nucleus is intact. But it has involvement of either the descending, either the kindothalamic tract or that descending, the kindothalamic tract is already crossed and coming. So that will produce sensory loss of the opposite side. Understand? And also sometimes because of the descending tract is getting involved, they can have this involvement of same side face. You understand? The kindothalamic is already from the nucleus, it has crossed and come. So if it is crossed and come, you get something means you get pain and sensory loss over the whole face. But the descending tract of the same side can get affected. So they can have various involvement of the same side. Touch can still be affected or not affected depending upon where chief sensory nucleus is affected. So there are that if those findings are there, you can write that it is in the brainstem. Understand? So sensory, this onion peeling, that various lamination. One is onion peel lamination, and you have other lamination also. That you know that, no? If you want, I can show some pictures. You know that lamination. Pictures you don't have. How you have the pictures? How onion peeling lamination pictures you have? You have seen?
Yes, sir, we have seen.
They will ask that onion peel. Otherwise, I will show you. Afternoon, I can show you. My laptop, it will be there. Okay. Then other brainstem, Horner syndrome. So the second thing is the descending upper motor neuron fibers to trapezius and sternomastoid, they don't go together. Trapezius is more anterior, sternomastoid is posterior. So if you have a differential involvement, if you see one fellow's trapezius, upper motor neuron paralysis of trapezius, with spared, I told upper motor neuron paralysis of trapezius means the contralateral trapezius will go. Without any affection of ipsilateral sternomastoid. That means one is affected, other is not affected. That means it is still in the brainstem. So differential involvement of upper neuron fiber to this trapezius and this thing, Horner syndrome, fifth nerve. Then how will you differentiate central from peripheral trochlear nerve palsy? Amrita, you have got a fourth nerve palsy, superior oblique is gone. Understand? So I am telling that your superior oblique, you are telling superior oblique is gone because of fourth nerve is affected in the cavernous sinus or superior orbital fissure or somewhere. But I am telling you, no, it is fourth nerve is one nerve where the nucleus is on the opposite side. Understand? Fourth nerve nucleus comes from the nucleus. After that it comes, crosses over the medullary velum and then comes and supplies. So if suppose somebody has got a fourth nerve superior oblique palsy, it could be either from fourth nerve of that side or nucleus of the opposite side. So how will you find out whether it is nucleus or the opposite side? So if you have a fourth nerve involvement, the superior oblique of affected here with the Horners of the opposite side, because sympathetic fibers are just adjacent to fourth nerve. So if you look for Horners of the opposite side, it is central fourth nerve. Here it is peripheral fourth nerve. If that is there, it is also brainstem. So internuclear, 1.5, Hornets, this various fifth nerve involvement, the differential involvement between supra, this trapezius, this thing. So then, which are the cranial nuclei which supplies muscle on the opposite side? So we have talked about say what is that, supranuclear. Supranuclear always it is to the opposite side. You will get from the same night. Now infranuclear, from the nucleus. Say fourth nerve, we know nucleus, it supplies the fourth nerve muscle, superior oblique of the opposite side. You understand? Fourth nerve nucleus supplies the muscle of the opposite side. Is there any other muscle? What is that? The superior rectus. Superior rectus nucleus supplies the muscle of the opposite. Nucleus supplies the muscle of the opposite side. So you look for any nuclear palsy of the third nerve. Nuclear palsy, suppose she has got a third nerve palsy, like that. She is keeping eyes like that. And you check for the opposite superior rectus. So if you have a third nerve palsy of one side with opposite superior rectus, then you know that she has got a nuclear third nerve palsy. Peripheral third nerve palsy will not produce contralateral superior rectus. Understand? Because superior rectus supplies the muscle of the opposite side. So other thing is, Darrow's clinical rule you should know. Say like that one is, Darrow's clinical rule is you suspect a nuclear third nerve palsy if you have a third nerve involvement of one side with contralateral superior rectus, or if you have bilateral third nerve palsy with spared levator palpebrae. These nuclear signs are there. Okay, lesion is mandatory nuclear. So third nerve, fourth nerve. Then another important thing which you should tell is sixth with 7. Understand? Which you will see. That is suggestive of brainstem. Sixth with 7. Understand? So all jugglery of cranial nerves only. Then you see told crossed weakness. Understand? Then lower down this trigeminal thing will help. So many things you can pick, no? Okay. So go. That's the next thing. I want to see the picture if you have. Corticus. That's go.
I do not have a picture, a photo of the person.
No. X-ray is there, no?
CT scan is there.
At least that we will know. The 77. No, he has got very good cervical spine for that. Yeah. There is some dislocation. No?
Degenerative changes are there, sir, throughout the cervical.
So you see dislocation is there, no? Between. So can you read this picture?
Yes, sir.
This is what she told correctly, odontoid fracture, everything she told. So you can read this. This is kept for examination. Is it normal or abnormal?
It's an abnormal CT scan, sir.
Yeah.
It is showing the CT junction and cervical spine, and it is showing degenerative changes at multiple levels. At C2 level, there are hypointensities and degenerative changes are seen, and a fracture through the odontoid body is seen, type 2, with atlantoaxial dislocation.
Atlantoaxial dislocation is there.
Yes,
It's there.
Is there on measuring?
Oh, just other CT picture can you show?
Yes, sir.
It is not there. There. Oh, severe degenerative changes. No?
Yes.
It's all fused only. Okay.
At lower level also from C4 to C6 level.
Just any other picture, no other picture.
Go back.
This is what she has, after seeing the history itself, you have seen the image. Next. Only these two pictures. CT is there. Okay. Okay, not there. Okay. How will you manage this patient? 77 years. Okay. The dislocation to me was not very gross from what you described. Mild dislocation is unless I see flexion extension picture. I cannot. You would have taken, no?
Actually, that was done outside, sir.
This was operated here, no?
This was operated here, sir. We have done CT scan. X-ray was with the patient.
I know, but you would have written on the case sheet, no?
There was, yes, sir. Between inflection extension.
There's severe dislocation. What was done for the patient?
We had done C1 arch excision, realignment of C1 and C2, and fixation.
What fixation?
With lateral mass screw and pedicle screw.
Lateral mass fixation, no? So, what are the various fixation procedures? Various fixation procedures for atlantoaxial dislocation. One is Gailey's fusion. You know what is Gailey's? At least for historical purpose, you should know. Gailey's fusion is not sublaminar. Understand? You are not going under C1. You are above C1 and then screwing. Sublaminar is Brooks fusion. Understand? Then you have McGrill's fusion. You have this. Halifax clamp, very good. Halifax clamp, transarticular screw, then lateral mass fusion. People do anterior fusion, everything. They will ask. So what you do is always lateral mass fusion here, no?
Yes, wherever possible.
Yeah. Okay. So patient did well, no?
Yes, the patient did well. He was extubated the same day, and he's at home now. His mobility has also improved. Paresthesias have been relieved. He's walking with one person support.
How will you differentiate non-compressive from compressive myelopathy? The selective involvement of some tract is more suggestive of a non-compressive. Understand? Compressive means, most of the things should go. Understand? Then, if suppose somebody has got pyramidal findings but preserved abdominal reflex, it is suggestive of non-compressive. Understand? So these things are the selective involvement plus preserved abdominal reflex will give you a clue. It could be everything could only, nothing is foolproof. Understand? Other things will look like compressive. What is the blood supply of the spinal cord? Last question, Amrita, before that, if you draw a cross section of the spinal cord, where is the pyramidal tract?
Anteriorly, medially and anteriorly.
You have equator. To the equator, where is it? Axial cut at C5 level. I am asking you to draw pyramidal tract. Where it is?
Paramedial on bilateral side of the.
How many percentage will be of that pyramidal tract is anterior to equator? How many is posterior to equator? Say 20%, 30 to 40, 60, like that. Entirely anterior. Again.
60% will be posterior laterally.
So, here 60%. You see, Amrita is telling totally anterior. The Amrita is telling.
No, sir. Then the some part which will be posterior lateral. I don't know the percentage.
So if in examination we ask to draw cross section of the spinal cord, if you cannot put the pyramidal tract correctly, you will have to come the next time. She is absolutely correct. It is totally anterior. If you touch that midline and draw, gone for examination. We have to come next time. Right? So now blood supply. What supplies the cord? Anterior spinal just runs like that, supplemented by so many radicular vessels, medullary vessel. But from the anterior spinal and all, it goes inside called the sulcal artery. How does sulcal artery supply? So anterior spinal artery runs like that. It is supplemented by other radicular vessels, medullary vessels like that. And it is fed like that only. From the center, from this it goes, sulcal arteries go inside. So after that, one sulcal artery goes, it goes to one side. Above that, it goes to this side. So no sulcal artery will go and supply both sides. Understand? And once it goes, it supplies only anterior-medial 2/3 of the cord. What I am telling is, lateral part of the pyramidal tract, leg fibers, sacral fibers, they will not get affected if the sulcal artery is going. They will remain okay. Only that medial thing will go affected. Understand? So that vessel will supply spinothalamic tract. It will supply this medial part of pyramidal tract. It will supply all anterior horns, canavona like that. Posterior thing it will not supply, posterior column. Understand? So you should know how that syndrome is. Lower limb part will be relatively okay, upper limb will go wasting like that. Understand? So between LMN and UMN, which is more disturbing, you told chapati, kipati and all. What you told, so many things patient cannot make.
Element is more disturbing.
Which one?
Element will be more disturbing
Okay.
than UMN.
It is UMN which is more. The other one, they are not disabled. LMN fellows, your motor neuron disease, if they ask them to excuse, they will spoil your hand. Understand? LMN will not be, unless they are bedridden, all like that. I am not talking a peripheral nerve will go. I am interested in anterior on cells and UMN. Anterior on is, after that, once it becomes peripheral nerve, they get debilitated. So I am only interested in anterior on cells to pyramidal tract. It is pyramidal tract, they get all this chapati, squeezing. They will do chapati all easily. They will make chapati for you also. Roti they will make for you. This small muscle wasting people. Understand? Other people, they cannot do anything. It is UMN fellows are more disabled. Severe spasticity fellow. Disabled only. Understand? Other fellows will not have any problem. Will have problem, but not disabled like UMN. Understand? Okay, so you should know everything. Every elbow is affected, what they can do. Shoulder is affected, what they cannot do. Everything is different. History itself you can tell whether if you hold a glass, whether they can hold it, if there is a gap somewhere, what is getting, if they cannot abduct the finger. So all you can take from history. A good history they will tell, you can tell whether it is flexor, pollicis or pollicis longus or abductor pollicis brevis or adductor muscle. Everything muscle you can get a history, whether triceps, whether biceps, everything good history you can tell. That history means you are telling in detail about weakness. You can get from a good history. Understand? No need. At least these things for you to pass exam only. After that you will not read. Understand? You will never ever read. So my one question to you is, she has answered some questions which I never thought you will answer. What was that thing you told? Bells, that I think it is more than that, you told something. So, what is Occam's razor?
Occam's razor is when one, it is always.
Where are you from? Which college you studied MBBS and all? Sikkim, Manipur.
Yeah.
Yeah. What is Occam's razor?
Occam's razor is that whenever there is one solution which will explain all the problems, that should be preferred over multiple reasons for something. So single diagnosis.
Simplest reason is often the correct reason.
Okay. So it's a law of parsimony. The simplest is always most of the time correct. So if you think of the easiest of the solution, that will be most of the time correct. Understand? So what is Hickham's dictum? What is Hickham's dictum? Hickham's dictum is just the opposite. A patient can have as many illnesses as possible. You don't have to tell this is from compressive myelopathy. You tell compressive myelopathy, peripheral neuropathy, everything you can put. A patient can have, don't confine yourself to one diagnosis. A patient can have as many illnesses as possible. Understand? What is Crabtree Bloodgene? Crabtree Bloodgene is, a very intelligent brain. A very intelligent brain can, whatever complicated things you give, that brain can put all the dots together. It will take some time. Understand? So our neurosurgeon's clinical assessment should be like that. You have so many dots. Suppose somebody tell you draw correctly and try how to get out of this, they will still be able to do that. Understand? What is Dunning-Kruger effect? Dunning-Kruger, people who are not skillful or they will pose as if they know everything. They cook up, they presume they are very big people, they can do everything without knowing anything. Without knowing, they are not properly, they themselves have not done surgery or whatever it is, but they will think that, they will tell that they can do everything and doing something with their, and cooking up. It is called Dunning-Kruger effect. Opposite of that is, imposter thing. They are very good people. They know, but they are not confident. They think, no, still I am not good like that. That is just the opposite of Dunning-Kruger. Understand? So these things you should know. Always, you should be confident like Dunning-Kruger. They are overconfident fellows. But you should also have something opposite of that. Some imposter also. You are good, but still you are little scared. Understand? Anything clinically, see, if you know arterional craniotomy, middle fossa, epidural approach, endoscopic approach, and something here, you have become a neurosurgeon. Rest of the thing, retrosigmoid you should know. CV junction you should know. That I think we have covered. CV junction, CT, but other thing is arterional, middle fossa here. And before I just finish, you do craniotomy, you do all skull-based craniotomy. You do this orbitozygomatic.
Yes, we have done, we do.
So you know about single piece orbitozygomatic craniotomy, single piece. You don't know, leave it.
One piece and two piece.
Not one piece I want to know. So if you are making a key burr hole, always you have, what is a key burr hole? McCarthy. So what is the importance of that burr hole? Both orbit and anterior canine fossa. You expose half there, half below. Anterior canine fossa above, orbit below. Understand? That is the key McCarthy's burr. Where do you make that burr hole? You have so many sutures there. So which suture, how many centimeters you make that burr hole? This is asked for examination. Where do you make key burr hole? So you should correctly tell, I will make from such and such a suture, along that suture, this many centimeters is the correct place where if I open, half will be in the anterior canine fossa, half will be in the orbit. Understand? Keyhole. From that keyhole, how will you take the bone flap out? So, the question is asked is, from the keyhole. So if I am making keyhole from here, keyhole I am making here. Understand? So from that hole you can say cut like that, cut like that. You can cut through this orbital rim. Understand? Keyhole through your craniotomy, you can cut like that, cut like that, cut like that, cut like that. Single piece you are removing. Then cut over the supraorbital rim. Understand? Then you have already made this hole here. Understand? Now you depress the globe here. Depress the globe and here you put a retractor there. Then you use your reciprocating saw. You are putting a retractor through this hole to protect the brain. You depress the reciprocating saw. You can see this hole here. If you depress, you have opened here up, you connect that to that hole inside. Understand? Then from that hole, you have to cut through to the inferior orbital fissure. So 3 cuts you are making. One you are making like that, other you are bringing like that, other to inferior orbital fissure. And then you have this zygoma. You understand? Your zygoma is here. So just above the zygomatic facial foramen, you cut that to the inferior orbital fissure. And then cut the root of the zygoma here. That is a single piece. Single piece. If you want, the people they have gone away from all that. Okay. So that also, sometimes it is asked a short note. A single piece FTO is it. So you should write like that. Okay, other things, so many things about everything. I use hardly little time. So you should read everything. I would have been happy to take you through other areas, but no time. Okay, now that madam's class is there. No? What is that actually? We have to go to lab, right? Lab. What is that lab?
Pathology lab.
Pathology.
Yes.
They have so much interest. She is the
Yes.
Head of the department.
Dr. Manjula, yes.
So I can ask her some questions also.
Yes, sir. She would actually really enjoy it.
Okay.
Lunch is ready.
Lunch will come. He is coming. Our Timmappa will come. I know. Just see. Otherwise, let me ask you. What is the current treatment of glioma? High-grade glioma.
High-grade glioma. Surgery,
Maximal
staging.
After that, high-grade glioma. Okay. After that.
Then temozolomide and radiation.
No, correctly you should tell. After that, followed by concurrent chemo radiation. How much radiation?
60 centigrade divided in 30 days total, 5 days a week and 2 days break, again like that, totally 65
Yeah.
60
So,
centigrade.
1 week you give 10 gray, Monday to Friday, and 2 grays each day, and Saturday, Sunday they can go for movie. Like that, they come for 6 weeks, finish that, 60 gray. Along with that, how much? 75 mg
per kg per meters per.
Very good. Like that you continue. After that,
After that, 1 month
150.
break.
After that,
A month break. After that, you need to continue the temozolomide.
take 150 to
150.
200 milligram meter square for
6
weeks.
6 cycles. No, six cycles. That is for the first few days. 1 to 5 days you give that. And after that, like that 6 cycles. Understand? That is a standard treatment. Understand? Which still people give. This is asked for examination. Okay. After that you don't know, I sent to Kidduwai, I sent to this thing, like that you should not tell. This much at least you should tell. Lot of things is happening every day. You see different things in pathology. One day they will tell this is low grade, next day they will tell this is high grade. So still we are learning because WHO 2021. They have come out with so many new things. Glioblastoma is disappearing. Understand? Anaplastic astrocytoma has disappeared. Fibroblastic is gone. Understand? So when we studied this protoplasmic, fibroblastic, glioblastoma, multiform, all these things are disappearing now. Understand? Now they are only all, what is that? Yeah, IDH wild type, IDH things or IDH mutated. Understand? Then you have 1P19Q to tell whether it's oligo. Previously oligo after all gone. And then you have this ATRX to tell whether this is this. And then you have some other, that genetic aberrations you should tell. Oh, they are telling photo, taking photo. Hey, take a photo with my camera. Because I will put it in my group. Come. Yeah. Hey, can you take in this? Come. Yeah. Okay, let that camera.
Phone ತಗೋ ಮೊಬೈಲ್ ಹ್ಯಾಕ್ ಫೋನ್ ತಗೋ ನಿಮ್ಮ ಕ್ಯಾಮ್ರಾ ಇರೋ
Okay, take. No problem. First, let me secure my. So I am gone and examiner to demand. No? So there is operating exam. Here you have operating exam. So there that time mobile phone was just new, maybe 20 years back or 25 years. And that time mobile phone and all, very useless phones also was very expensive. It can just come on. Very useless phones at least very costly. And then Shastri was so upset. He issued anybody else. Then they told the man changing room, 100% it will disappear. Kept it back. And then they couriered it. They got it. And this pen, this pen is such an ordinary pen.
Welcome to Majumdar Medical Foundation, where we do translational research which originates from bedside, that's from the clinicians, and the result is delivered to the patients. So it is, rather than from bench to bedside, we do translational research from bedside to bedside. So the Majumdar Medical Foundation ecosystem consists of 4 major groups. One is definitely the largest, that's the research team, which is Majumdar Center for Translational Research. The others are more towards the market, I would say. So one is the ADRC, which is the research lab, Advanced Diagnostic Research Lab. Then TBI, which is Technology Business Incubator, and Majumdar Shop outreach program for the cancer patients. So I will, except for this MS Corp, the outreach program, I'll take you through the little more details about the other programs. So in MSCTR, as I mentioned, that we do research there, exploratory research there, translational exploratory research. And where do we get the people force? That is through the workforce is mainly through the academic excellence program, where basic science graduates, they can get their PhD degree. They can also do internship with us. And not only the basic science graduate, even the clinicians, they can not only collaborate, they can do their PhD, they can work at MSCTR for their DNB projects. And this from MSMF, that's how we provide the value-added translation to healthcare, which cannot be complete without the source, the hospital, the patients, the clinicians, and I would say that on the way, again to come back to the hospital, another major component is the industry, because unless until the industry participates. We can't, the products which we are taking out or the product prototypes which we are thinking of, we cannot ascertain the production of those, the quality of those, and actually mainly it's the quality and the production, the quantity. That's what comes from the industry. So that requires a different kind of expertise and different kind of infrastructure, mindset, so which also we have included in the MSMF ecosystem. So the first about the Translational Research Center, which is the MSCTR, it has mainly 3 major exploratory programs: integrated head and neck oncology, neuro-oncology program, and molecular immunology program. Along with these 3, I would say maybe disease specific programs, we have 2 major programs. One is the computational biology. As you know that biology or even clinical research is incomplete now. It is completely interdisciplinary. It is incomplete now without the analysis of the data, without the analysis of the images. So the computational biology overlay on this is also, we have started this as a new department now. And the other program is the product research program, which is, as I mentioned, that whatever product prototype which we are making, unless and until we can make it through the regulatory guidelines, we can make it market reachable, we can't really take it to the market. So as I mentioned that we do, it starts from discovery. We can take it through the preclinical validation where we check the efficacy of the products. Then we also do the validation in patients with the help of the hospital. We do the validation in patients. Finally, the product development, that means that we liaison with the industry, we take it out to the industry. Little more about the academic program, because this is the major workforce actually comes from here. So the degrees which are offered are from with MAHE, with that is Manipal University of Higher, Manipal Academy of Higher Education, Vellore Institute of Technology, and Rajiv Gandhi University of Health Sciences. Through these 3, we offer the degrees. As I mentioned that we have for science graduates, we have a program, a doctoral program, postdoctoral program, and internship. And even for clinicians, we have doctoral program. We have clinicians, the clinicians are also under our GUHS. The clinicians also can act as guides. They themselves can take PhD students. And of course, we have internship programs for clinicians, which can be from 6 months to 1 year. And collaboration, like on top of all of these, we have collaborations with the clinicians where even the DNB students can do collaboratively, they can do their projects. We have an entrepreneurial fellowship program in collaboration with the Technology Business Incubator, and even those companies who are incubating there, they also can participate in the PhD program. So under the science exploratory science program, we have around 10 PhD students. And for the clinicians, the program for the clinicians, we already have 3 clinicians registered with us for PhD. And from MSMF TBI, we have registered a person from a company who also happens to be a clinician. So our infrastructure allows us to do omic experiments. That means that if we can do a lot of sequencing, proteomics on patient samples. So from that, whatever we generate, we can do like through our informatics program, we can analyze those data, we can form the hypothesis, we can validate those not only in vitro models. In vitro models are cell line models or cells which we take from patients. We can immortalize those samples and we can validate them on those kind of patient samples. And after that, as the next level, through our collaborators, we can also validate them in preclinical models, and then we can take it out to the market. As you all might know, that we have along with NH, we have a very big biorepository where we can store the patient samples, different kinds of patient samples, starting from tissue to serum, different kinds of blood components. We can store all that, and we can also store the images. So these kind of components, this kind of human components and the images together would can give us a lot of data, which we have the capability of perturbing those models and coming up with even more data by advanced techniques, which is say something like FISH. We can do qPCR, we can do droplet digital PCR, we can even do NGS now, and we can generate a lot of data which will help us to generate the hypothesis. We can do a lot of these things through our collaborators. Our collaborators, as you see here, we have academic collaborators like ISC, different IITs, then IOB, and in India, and of course even abroad we have collaborators like University of Dalhousie, and multiple, all our alma maters actually we collaborate with all of them. We have companies also as collaborators like Syngene, Biocon, and places like NeoDX, where we can develop kits, and also not only NH, many other hospitals are also our collaborators. The funding, the seed funding is of course from Dr. Kiran Majumdar-Shaw, but after that then we have funding from ICMR, DST, DHR, DBT, SERB, multiple government organization. We have international funding from NIH, and also we have private funding from different companies. So we have started, though I would say that we started in 2013, but operation actually started maybe 2014, in last 4 or 5 years. A few of our achievements which I will take you through when I discuss the groups. So the first group, which has been, that's actually the first group to start in MSMF, that's integrated head and neck oncology. Dr. Amrita here, she heads the integrated head and neck oncology program, and she's also the operational head of MSMF. And in this program, I wouldn't spend too much of time on these individual programs, just to tell you that we have majorly 2 types of program. One is the oral cancer control program, which is through regular camp and regular screening. They try to detect the cancer early and try to prevent it. And the other one is the oral cancer therapy program. So one of the major components in that program is the cancer stem cell mediated drug resistance. That's one area that they work on. And maybe sometime, if you are interested, we can discuss with the group, and we can know more about what is coming out of that group. The second group, which you might be more interested, is the Neuro-Oncology group. So after this presentation, we will have little more detailed presentation by Dr. Atanu, who will present the programs, so the details of the programs of Neuro-Oncology. The third group is molecular immunology group, which is headed by me. So we have two types of program. One is the immune perturbation by virus, and the other one is immune perturbation by cancer. So in virus, as we can imagine that whatever we have last 2 years, we have worked a lot on the COVID. So the things that we have done is that in collaboration with another diagnostic center, we have screened more than 2 million individuals, and from that, from that then we have developed, we have come up with, and in combination with the public data, we have come up with different immune markers, and we are validating those right now. We have also a survey of the immune status, which is a survey to evaluate the B and T cell B cell immunity status of the symptomatic and asymptomatic patients, and in their association with the HLA status. This is one project which we are doing with Dr. Ram Mohan Bhatt here in NH, and also Dr. R.K. Prasad, who has this diagnostic lab. And for the other part, which is the perturbation by cancer. So in this, we have two types of projects. Right now, we have two types of projects. One, to understand the tumor microenvironment crosstalk, and the other one, and the second one, is that HLA dependent immune activation. Right? Based on the HLA, as you know, that in cancer there is failure of immune surveillance. How can we stimulate the immune status of the individuals to get back to the immune surveillance so that immune therapy can succeed? Then the other group, the more recent group, is the product research group, where the mandate of this group is to make the products market ready, and also to do product research to improve the efficacy and production of the existing products. Look for novel platforms. The type of products that we look at are diagnostic and therapeutics. Our technical capabilities are, as I already mentioned, we can make cell lines from patient samples, and we can develop different kinds of molecular diagnostics. We can develop immune diagnostic starting from making the standard proteins, the antibodies. We can develop the assays based on this, and also we can develop the biotherapeutics. We can develop the entire thing in-house. So couple of just small examples. One of the example of the diagnostic is that we are almost like close to completion for a diagnostic product, which is an impedance analyzer, small device which we are making in collaboration with ISC, that is for early detection of salivary biomarkers for oral cancer. The proteins and the antibodies have been made in MSMF and in collaboration with ISC, who is making the device. So there, right now it is working. We are seeing that the sensitivity is up to picogram level. As you know that in cancer patients, when especially in saliva, the amount of the proteins are very less. So we need very, very sensitive assay. So this is one kind of platform that we have developed, and this is almost near completion. The others are, as I mentioned, that biotherapeutics. So one, we have developed one of the anti-COVID agent where we have fused the receptor of the virus, which is the ACE2 protein on human cells, with the FC portion of the IgG, human IgG, and made a fusion protein which can trap the virus as soon as the virus enters. If the molecule is already there in bloodstream, it can trap the virus and doesn't allow the virus to get inside the cell. Another such molecule is the anti-LCN2 monoclonal antibody, which is being tried now in colorectal cancer. So some other time maybe I can take you through the details of this, but the main thing is that we can, once we have target, we can make the antibodies, we can make recombinant antibodies, we can make therapeutic proteins, and basically biotherapeutics. The computational biology program. The computational biology program right now is headed by Dr. Shujan. Tomorrow you will hear more about those programs. Mainly two types of projects that they run. One is data-based. That means that the data that comes from the patient, that comes from the experiments, that comes from the diagnosis. So from those data, they form various hypotheses. The other one is from the images that we generate a lot of from the patients. We can generate a lot of images, and those images also in AI based through like AI based models, we can generate different kinds of hypotheses from there, and then we can also validate those. So you will hear more in tomorrow through one more talk. And then we come to the Advanced Diagnostic Research Center. So here it is not only that we develop the diagnostics, we also do research on the samples which we collect through this. So the mandate, as I mentioned, that mandate is to make diagnostics and also to do research on that, to improve the efficiency of the available diagnostics, to also get to novel diagnostics, also do validation on patient samples, and also to get to novel diagnostic markers. So far, the diagnostics that we have developed are, we have developed the Neuro-Oncology panel, about which I am going to talk tomorrow, and the other one is the transplant panel, which like it's not that we have developed it, but we have started offering it. So NH, like this center, is one of the largest transplant center if you put together heart and lung, kidney, liver, bone marrow, everything together. So there is a great need for offering the transplant diagnostics at this center. So we are trying to become like first trying to help all these clinicians, and trying to become, like through that we have formed a transplant immunology group and trying to develop even near diagnostic through this. So then I would come to the last but not the least, the technology business incubator. So the business incubator, that is not in this building, that's in the international wing, where we will go after visiting our facility here, where we will go. So you will see the facility there. So it is around 12,500 square feet facility, where different companies can have their own space to have small research labs, even have small benches. And how it works is through the NH ecosystem. So the TBI, it can collaborate with, by being here, it can collaborate with the NH clinicians, and not only the clinicians here, with the entire clinical network, and also it can work with the scientists at MSCTR, so that they can do their developmental research, they can do their validation, and also they can do their clinical programs. They can run their clinical programs, they can do their clinical trials along with the clinicians. And most important is that through the entire process, they can be guided by the clinicians. So few of our incubators, we have right now we have around 14 incubators, and so they can incubate here. The startup companies can incubate here for a certain period of time. I think 3 to 5 years they can incubate here. After that, so we have 18 of the companies who have already graduated. That means they have completed their period and they have moved out. So the prototype lab and other things I don't have to show you, but now we can actually, when we are going there, you will see the prototype labs, the electronic labs, the mechanical shed. So that's also near the other parking area. So we don't have to go there, but there we have kept a lot of engineering instruments where the companies can use, and they can have their small lab here. We have an advanced AI lab here in that building, and these are our partners for funding. So they also bring in more funders through their contacts, and then our other hospital partners. And with that, I think that this is our small scientific team. So you all know Dr. Paul Sullins, who is the MD of MSMF. So with him, many of you know Dr. Moni Kuriakose, who actually one of the most instrumental person to start MSMF. So he was here, head and neck, he started the, yeah. And with him, all 4 or 5 of us are there. You know Dr. Ravi Deshmukh, who started the Neuro-Oncology team, and now it is, I can hand over the talk to Atanu, who has joined recently, and he's starting his program here, the Neuro-Oncology program, to take it forward. Okay. Thank you, and so this is our MSMF team. Atul, you can come and you can start.
Thank you, Dr. Manjula, for a good introduction and overview of our MSCTR activities. And I would like to thank Dr. Amrita and my mentor, Dr. Ravi Sardesmukh, and also the organizing committee of this symposium, Dr. Komal, inviting me and giving me the opportunity to introduce our Neuro-Oncology program from MSCTR, MSMF. So we have right now very small group, but we are expanding. So to start with, I just give a small background of my research. So I was in Tata Cancer Hospital, Actrek, in Navi Mumbai for more than 4 years, 4.5 years, and there I studied during my postdoctoral training. I studied mainly therapy resistance in GBM, glioblastoma, under Dr. Silpi Dutt lab, and with several clinicians collaboration. So what we understand during last 4-5 years, or what we are thinking, that there is a major challenge is to understand the therapy resistance in GBM in a proper settings. Like we all know, here we are all clinicians, that there is a lack of a sample after treatment or therapy, because we can't do multiple biopsies, or we can't do multiple sample collection after treatment or during treatment. And these therapy resistance are coming during treatment, and that's why it is difficult to understand what is the molecular mechanism and how it is happening. If we don't understand that, then it is difficult to find out any prognostic marker or any diagnostic or even therapeutic purposes. So it is very important to understand that therapy resistant mechanism. So in TMC, during my study, we developed an in vitro model where we can study this therapy resistance in GBM, and then we correlated this model with the clinical sample, with patient sample, 20 patient sample we have taken, and we showed that this model is actually telling the therapy resistance in clinical setting. So we take the survival of those 20 patients and we correlated our in vitro data, and that we published in Cellular Oncology. Then using that model, we understand how these therapy resistant cell or residual disease cells are surviving. So what are the mechanism of their DNA repair pathways so that they are surviving this treatment, and that we published in Neuro Oncology, and there we have found these cells are capable of to survive this radiation, and they have some DNA repair pathway which is unique from the other setting. And then we target, this is one target candidate based approach where we target PARP1, which is a DNA repair protein, and we know all that PARP inhibitor olaparib is in clinics for ovarian cancer, mainly BRCA mutated cases. So we choose this molecule to understand if there is any sensitivity in radiation therapy in GBM or not, and then we found yes, if you treat these cells with PARP inhibitor, we can prolong this therapy induced senescence phase, and it can delay the recurrence in vitro model. Even we proved this in preclinical orthotopic mouse model. So all these experiments have been done in orthotopic mouse model, GBM mouse model, and so that means this therapy resistant in vitro, what we found that these cells are in a senescence phase, and that nowadays people are calling is a tumor dormancy. And this tumor dormancy, due to that, you can develop the resistance for against several therapeutics or drug. And then we also found in another aspect, we wanted to study whether these residual cells or resistant cells, whether their metabolic activity or bioenergetics, whether they are different from the parental cells or not, or primary cells or not. Then we checked and we found that this one molecule 1433 zeta, which is which can be used as a marker, prognostic marker for this residual disease cells or therapy resistant cells in GBM. So these are my background where we studied this therapy resistance. Now I am incorporating this background in MSCTR, to study this GBM therapy resistant along with other ongoing projects. So basically we are working on glioblastoma, GBM, and we are addressing several clinical questions. And there is another tumor we have just initiated, that is pituitary tumor. Dr. Kiran is here. So with the question coming from Dr. Kiran, we are now addressing this pituitary tumor, whether we using omics analysis, we want to understand the aggressive and non-aggressive form of these adenomas, and from there we want to make a molecular stratification, and we want to identify prognostic marker or novel therapeutic targets. So these are based on pituitary background. Now in GBM already our MSCTR under Dr. Ravi Sardesmukh, we have ongoing projects like we study this post-treatment surveillance, and under that we wanted to study the samples based on whether they have recurrence property. We can have any markers which can tell their therapy responses, and last 5, 6 years or 10 years we understand that there are molecular signatures, or using molecular data we can understand the cellular difference. There are several cellular cell type in the GBM. One is the proneural to mesenchymal transition, that is mesenchymal form is more radio resistant or therapy resistant. So we have several MES signature molecules that we can use as a blood based marker, and we are also trying to understand several microRNA regulation and metabolites in the metabolism of those GBM cells, so that this can be used as a blood based marker. And recently we are also in a collaborative discussion with clinicians, radiologists and radiation oncologists, whether we can use these MRI images and MRI features, and collaborating those MRI features with molecular signatures like mesenchymal phenotypes or any molecular targets. And if we merge these two things, and we can predict some treatment surveillance aspect. So that is also ongoing. On the prognosis part, we are working on different mutation profile of GBM, and we know GBM are highly immune cells are infiltrating, immune cells are there, so immune cell phenotyping in high grade tumor. Apart from that, there is one project is ongoing, that is to identify novel peptide or splice variant which can be used as a prognostic marker. These things Dr. Ravi will speak tomorrow about details. And we have another project where we are from our earlier omics data, we have shown that in GBM there is one immune response pathway, that is granzyme pathway, which is suppressed. So now we wanted to understand what are those factors which actually giving this suppression of this immune response, and from there we can also get some prognostic, or in a therapeutic purpose we can get some targets for this aspect. And now this therapy resistance I will tell you in detail. So in therapy response, therapy resistance and sensitization, in this project what we want to do is that we have experimental system like clinical samples, we have cell line model, we have tumor or patient derived cell lines, and we have 3D culture, 3-dimensional culture, which is more close to the in vivo setting. And also we are trying to establish organoid model to address several these questions what I have discussed. And we have the approaches like cell-based approaches, gene modulation or functional studies, and also multi-omics approaches where transcriptome, proteomics will collaborate all these things to address this question. So under this treatment resistance and sensitization, what I have found in my postdoctoral training, those experience we will utilize here, and we want to study and want to find out any novel radiosensitizer or chemosensitizer from this study. And another 2-3 subject we are focusing, that is one is the senescence, what I have told you, that therapy induced senescence, which is like a tumor dormancy. So we have extensive data in that field. So from there we can take some markers or some signature molecules which can be used for this treatment surveillance purposes, or maybe in a therapeutic target So that things are under we are trying to understand in a detail so that we can initiate that project. And during my postdoctoral training also, we have found there are some difference in primary and recurrent tumor in terms of telomere length. So that there is an indication, so that these features also can be used as a molecular features in our MRI based treatment surveillance. So that in a separate way we can understand or we can study this, this subject. And also already I have mentioned that PARP molecule, that inhibitor is used in my earlier study, and that we have found a very good response. But again, to get a better response, combinatorial therapy or combinatorial approach is better, and that's why maybe we are looking for another those type of DNA repair proteins which are highly expressed in GBM, and also which are coming after treatment. So we can target those specifically so that we can get a better therapeutic responses. So these things we will address in 3D model or microarrays model. There are one project is going on where using this 3D model or microarrays array model, we can able to identify slow migratory and fast migratory cells, and from there we can collect those fast migratory cells and we can do omics analysis and we can understand what are the molecular signature or molecules are responsible for this fast growing cells, because we know these are very invasive cancer type of invasive. So that can be studied, and that is actually going on, and so we can use this all two-dimensional study in 3D model also. And recently we have published one paper in this GPR56 and TG2 story. These are a ligand, receptor ligand thing. So I will not discuss the details about it, but the main take home is that these molecules are very important for proneural to mesenchymal transition. And we all know that mesenchymal form are the radio resistant form, and they are also they have the stemness property. So these cells are very hard to kill, but these molecules are actually correlate with this transition. So if you target these molecules, then we can get a better therapeutic responses. And also we are also trying to understand the tumor microenvironment in terms of hypoxia, how this hypoxia is actually regulating this therapy resistant phenotype. So all these things are is going on, and some part are actually in a thought process. We are doing that. So we will in the near future we will do good things about this neuro-oncology therapy resistance. So that's from right now, and Dr. Ravi will discuss tomorrow other aspect of our program. Okay, thank you all for attending this.